Dalex Pharma International is a Filipino-owned and managed pharmaceutical and medical device company with the aim to bring affordable and quality medicines in the ICU setting. Home of Dalex ICU Forum, a train-the-trainers program to raise the standard of critical care practices. Your prescription doesn't just save lives, but they transform lives to our CSR program. Care LGL and Dalex Pharma introduce NeutraClear, a completely transparent neutral displacement connector that prevents catheter-related bloodstream infections. Its exclusive design guarantees that best practices are followed and ensures patient safety. NeutraClear's smooth, flat septum makes it easy to disinfect. The guiding seal ring protects needleless connector's integrity. Its 2.8 cm size and 1 gram weight reinforces care comfort in neonatology and pediatrics. The neutral displacement design prevents blood reflux in the catheter. Thus reduces the risk of occlusions and infections in the catheter. Its completely transparent needleless connector ensures best hygiene practices and is recommended by experts for effective flushing. NeutraClear, the closed system which guarantees neutral displacement and complete transparency to prevent catheter-related bloodstream infections.
Sepsis, a life-threatening organ dysfunction caused by a dysregulated host response to infection. Sepsis and septic shock are major healthcare problems, impacting millions of people around the world each year and killing between 1 in 3 and 1 in 6 of those it affects. Shock is common in critically ill patients with COVID-19, developing in up to 67% of patients in intensive care and is associated with high mortality. In the recent guidelines issued on care of critically ill adult patients with COVID-19, norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. But sepsis and COVID-19 do not only affect the health of the patient. Sepsis and COVID-19 can cause financial burden and has an impact in the environment as well. Although there are positive effects brought about by the lockdown, there is a growing concern in the increasing medical waste generated from hospitals and public's use of disposable safety equipment. Brought about by sepsis and COVID-19, there is a need for an ideal norepinephrine solution to manage hypotension due to shock to achieve mean arterial pressure greater than 65 mm per mercury. A cost-effective norepinephrine to help alleviate financial burden, a norepinephrine that cares for the environment. Norepin is an ideal norepinephrine solution based on clinical studies and guidelines. Norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. Norepin passed the Institute of Pharmaceutical Sciences National Institute of Health in UP Manila with an assay test result of 106.7%. Norepin is cost-effective compared to the Innovator brand and can provide a savings of up to 23,000 pesos. Norepin 10 ml preparation can cut the number of ampules to be opened by 40% compared to the Innovator brand. Thus, it helps lessen the medical wastes. Moreover, Norepin 10 ml preparation has the following advantages. Be a part of our CSR advocacy and World Vision. Your prescription doesn't just save lives, but transform the lives of these children in World Vision. Every time you request Norepin at the pharmacy means sending a child to school and help fulfill their dreams.
Hello, everyone. May I invite everybody to kindly stay tuned as we will start our program after we show some important Zoom reminders, followed by a short invocation, the Philippine National Anthem, and the Sisinapi hymn. Thank you.
The Sisinapi Online Learning Reminders.
Background noise. See that there is no disturbance like background noise or people moving around to avoid distractions. Sit in a good lighted and noise-free room. Test equipment and internet speed. Check laptop, desktop before joining the webinar. Choose a spot with an unlimited and strong internet connection. Use headphones or earphones to reduce the background noise. Log in on time. Be on time. Join every session at least 10 minutes prior to the session. Value other people's time. Mute your microphone and camera off. Please put your microphone on mute and camera on off during the session to avoid interruption of the presentation. Be polite. Do not interrupt. Leaving the session. Do not close or leave the Zoom application during the session to avoid being logged out that will result to incomplete attendance. Asking questions. All questions will be entertained after the presentation. You may type your question on the chat box so that the moderator can take note of it. Please keep your questions minimal and on the topic. Be prepared for technical difficulties. Just in case of technical glitches, kindly send us a message through email or social media outlets or through SMS. Profile and display name. Choose a suitable profile picture. Name yourself formally the way you want to present yourself. Certificate of Attendance. Certificate of attendance will be given only after the participant has accomplished quiz and evaluation. The QR and link will be shown on the screen and will be emailed. Automated certificate will be sent. Make sure to input your correct details. Self-directed learning application. The certificate of attendance for this online session may be used for PRC's self-directed learning application. The organizer will provide you with a certificate of attendance together with a PRC guideline on how to apply for self-directed CPD units and the application form. To maximize your self-directed learning application, you can collate all the certificates of attendance that you earn from webinars into one self-directed CPD application. This will consolidate all the credit units for the required year or for 3 years. For renewal of your PRC ID, you need as much as 15 credit units earned for the 3-year period. For other concerns, please feel free to contact us.
Our Heavenly Father, the fount of all goodness and grace, the cause of wisdom, the source of intelligence. We welcome you, O Lord, to this auspicious gathering of your beloved, who continuously give you thanks for every opportunity to learn something new and become fruitful to the works of your creation. We humbly come to you, not because we are worthy, but because we find ourselves in need of you, who is our strength and our hope, to continue despite the challenges we face in health, prosperity, and our solidarity with one another. We pray that today's gathering, made possible by the grace of advancements in technology and social media, become successful in its endeavors, so we can offer it back to you as our humble offering to honor you glorify you, and love you through our deeper connection with everyone. May we find bliss in today's session and become more productive children and co-creators of the earth. This we ask and pray through Christ our Lord. Amen.
At Cincinnati, we care for a better world. This is our passion, beyond our profession, committed we'll ever be. To learning, training, we continue equipping, be the best that we can be. To care for humanity, we draw strength from God Almighty. We care for patients to restore their optimal well-being and live a life of quality. See healing flow through the love we sow. With high touch, high tech at Cincinnati, we care for a better world. The world needs more people who care, and we are a people who dare. We give all we are, we give only our best. We are the Critical Care Nurses Association of the Philippines. We are Cincinnati. At Cincinnati, we care for a better world. This is our mission, our pledge to the nation, committed we'll ever be. To learning, training, we continue equipping, be the best that we can be. To care for humanity, we draw strength from God Almighty, and through Him we set people free. From darkness we hold on to life and see healing flow through the love we grow. With high touch, high tech at Cincinnati, we care for a better world. With high touch, high tech at Cincinnati, we care for a better world.
Good day again and welcome everyone. Thank you for joining us in today's webinar brought to you by the Critical Care Nurses Association of the Philippines Incorporated and the Philippine Neurocritical Care Society with Delex Pharmaceuticals as our Zoom provider. Our webinar is entitled World Stroke Day, a closer look in post-operative care of hemorrhagic stroke. Today, we will celebrate the World Stroke Day. This campaign was initiated by the World Stroke Organization, which is a global body solely focused on stroke. This activity is an opportunity to raise awareness on the serious nature and high rates of stroke. It is also an opportunity to advocate for action by decision makers at global, regional, and national levels that are essential to improve care of stroke patients and support for survivors and caregivers. My name is John Christian Agustin. I am the Vice President of the CCNAPI, and it is my privilege to be your moderator for this program. So let me give you a brief information about our activity. This is a 4-hour webinar that aims to provide nurses an overview of neurological post-operative care of patients who suffered from cerebral vascular accident, specifically hemorrhagic in nature. Moreover, this program will further develop critical assessment skills in handling contraptions and drains of cerebrovascular challenge patients that will serve as a key instrument in avoiding complications post-operatively. In addition, this educational activity celebrates World Stroke Day, a campaign initiated by World Stroke Organization. Next. And our specific objective of this program is that it first explains various surgical interventions done in hemorrhagic stroke, elaborate roles of a critical care nurse in handling immediate post-operative neurovascular patients, provide evidence-based techniques that a healthcare provider must utilize to avoid post-operative complications, describes medical, cognitive, and functional complications experienced by stroke patients, and lastly, present various methods and scoring systems in identifying risk for post-stroke complications. As you can see in your screen, that this program is applied for 4 credit units. Kung makikita nyo po sa screen nyo, ito po programa po natin, in-apply po natin sa PRC CPD for 4 credit units. Unfortunately, we're still waiting for the confirmation kung ilang CPD units ang ibibigay po sa atin. That's why it's still on pending status. But rest assured, it's applied po. Moving forward to our first topic for this morning. Our first topic will give us an overview of the nursing care needed in a post-operative hemorrhagic stroke patient. To discuss our first topic, we invited a product of Centro Escolar University, Mendiola, Manila, where he also took his Master of Science in Nursing. He started his career as a registered nurse at St. Luke's Medical Center, Quezon City in 2007, and as he climbed the ranks, his passion and love for critical care nursing grew. He received multiple citations and awards from the same institution, and in 2019, he was a finalist in a nursing research presentation, and he was also awarded as the Associate of the Year in Junior Managerial category in 2022. Furthermore, he received a travel grant from the Neurocritical Care Society, where he is also an active member, to attend the 2018 Integra Foundation US Convention. Currently, he is the Nurse Unit Manager of the Neurocritical Care Unit of St. Luke's Medical Center, Quezon City. Without further ado, let us virtually welcome Mr. Mark Angel M. Dizon. Mr. Dizon, the screen is yours.
Good morning, everyone. So I hope all of you are doing well. And this is a nice day to observe and take part in the World Stroke Day as we celebrate the role of nurses in taking care of our patients, especially those with hemorrhagic stroke. So next slide, please. So our objectives at the end of this particular presentation is that we will be able to acknowledge the different roles and responsibilities of nurses taking care of post-stroke patients, especially those who are in the intensive care unit, whether it be in the neurocritical care unit or in the medical surgical ICU, where we also cater stroke patients. Two, we will be able to discuss which particular neurosurgical procedures are common among Filipino patients, and especially those who we took care of. Number three, to provide the best practices using a different approach. For this time, we will be using nursing models in caring for stroke patients in the post-operative phase. Next slide, please. So, why nurses? We as nurses take care of stroke patients, but sometimes we tend to neglect or forget our particular or very important roles that we have. So I cited here the most common and very beneficial things that we are doing for our patients. So this includes the following. First, doing nursing interventions or procedures which are tantamount of importance for optimum patient outcomes. So this would include from the time that the patients come into the unit, where we do our health teaching and health education, up to the time that they receive their post-operative care. Number two, we nurses are geared towards using evidence-based practices in establishing national guidelines. Currently, the Stroke Society of the Philippines, as well as with the other health organizations and nursing organizations, are geared towards aligning the different hospitals in making sure that each of them have a particular specialization for stroke care. So ano pong ibig sabihin nun? Ang goal ng Department of Health by this starting 2022 up to the next 3 to 5 years is to make sure that as much as we can, we will be able to specialize hospitals or give them the opportunity to take good care of stroke patients and be certified. Meaning po, they will be categorized as hospitals particularly taking care of stroke patients. So this is important because our national guidelines is centered on decreasing the morbidity and mortality due to stroke, because stroke itself is one of the major causes of mortality for the past 5 years among Filipinos. So number three, nursing leaders, especially those in the admin, must ensure compliance to standards of practice to obtain a holistic well-being. So next slide po. This particular slide shows us what the Monroe-Kelly doctrine is. So you can see here that we have the four particularly four components. Actually, it's three. We have the blood, the brain, and the CSF. So these three components are inside the skull or the brain. And then the blood is divided into your venous and arterial. Next slide. Next slide, please. Ayan. So for this particular picture image, you can see here that if there is a venous blood, arterial blood, a brain, and a CSF, if, for example, there is a particular mass that is inside the brain, the Monroe-Kelly doctrine just tells us that if there is any adjustment or any increase in volume in any of the particular components, the others will try to compensate for it. So for example, in our case, we are discussing about a hemorrhagic type of stroke, meaning the blood itself from the patients is increasing in volume. So what will happen? The brain or the tissues, as well as the CSF, will then compensate. They will try to decrease their volume to compensate for the increasing volume of the blood inside the cranial vault or the skull. So para siyang nawasa. Ang ibig sabihin nun, pag binuksan mo ang gripo, ang mangyayari dyan is yung nasa loob na pressure, itatry niyang i-compensate hanggang sa point na hindi na niya kaya. That's where your increase in ICP will come in. So the Monroe-Kelly doctrine just says to us that if any of the particular three brain components increase, the other two or the other one will try to compensate up to a saturated point where it cannot longer do its compensatory mechanism. So after the point na hindi na niya kaya, dyan mangyayari yung mga tinatawag natin na mga herniation syndromes. Next slide, please. So as you can see on the screen, we have the normal, compensated, and decompensated pathway of the Monroe-Kelly doctrine. If, for example, you can see on the left side, this is the normal. We have the brain, the blood, and the CSF and the venous blood. If there is a particular mass, as you can see, the other components will try to decrease themselves up to a point that it can accommodate a certain level. But if in case the lesion or the blood is too big, herniation will then occur. Next slide, please. So as nurses, what are the things that we need to watch out? So I cited here the early and the late symptoms that we as nurses need to be adept and aware of at the bedside. Elevated intracranial pressure includes the following signs and symptoms. For the early stages, this would include presence of headache. Most especially, they are describing it as a throbbing headache or most severe headache of their life. Presence of irritability, vomiting. So for vomiting, you need to take note if the patients had projectile vomiting. This means that the pressure is too big or there is an impending herniation that might occur. Presence of photophobia, nystagmus, and diplopia. Presence of lethargy, meaning yung patients kung kanina, gising na gising siya, this time, medyo nahihirapan ka ng gisingin ng pasyente. And presence of seizure. For the late signs of increasing ICP, we have your changes in sensorium. Most prominent for this one is a Glasgow Coma scale of at least 2 or more. So if, for example, your Glasgow Coma scale for your patient is 15, then after checking it for an hour, it decreased to 12. You have to make sure that you also inform your neuroresident or your hospitalist or your consultant that your findings are of significant amount so that they would be able to assess your patients. Ipsilational change in your pupillary sizes, shape, and light responsiveness. This means that if, for example, both eyes, for example, today is 8 o'clock in the morning, the pupils of your patient are 2 millimeters, equal and briskly reactive to light. And then after checking it for an hour at 9 a.m., the left pupil is much bigger than the right. So you have to make sure that you also inform your physician about it because that is called anisocoria and it is a bad sign. Next, contralesional hemiparesis, which can be a new onset or a worsening one. Contralesional change in the pupillary size or the Kernohan's phenomenon. And then the last one is your Cushing's triad. For patients with neurodeficits, Cushing's triad is the most significant one, especially if your patients now is at late increase in ICP. So it means triad. So you need to watch out for the 3 symptoms. First one, you have an increase in your systolic BP with widening pulse pressure. An example of this one is, for example, your patient's blood pressure initially is at 140/90. After 1 to 2 hours, the BP suddenly rise up to 200/90. See you can see that there is an increase in your systolic BP, but at the same time, you can see the difference between your systolic and the diastolic. Hindi po ba malayo ang agwat na 200/90? Dapat yan at least mga 200 over, say, 120 or 180/90. Pag masyadong malayo yung agwat between your systolic and diastolic, plus at the same time, biglang tumaas yung systolic BP ninyo, that's one of the triad of your Cushing's triad. You also need to monitor for bradycardia or decrease in heart rate and irregular respirations. For stroke patients, most commonly they do have is your Kussmaul's breathing or your Chine-Stokes breathing. Ibig sabihin nun, irregular yung pattern ng respirations po nila. Next slide, please. For this particular slide, we can see here the critical neuroexam findings of the pupils or the eyes. You can see here that the pupils or the one on the screen, the one with the dark, yung color black sa gitna natin, you can see that they are not the same. One is bigger than the other one. So this is called anisocoria. Anisocoria means difference in pupillary sizes. The left eye is different from the right eye. This is an emergent finding that is specifically seen in patients with depressed sensorium or those with beginning herniation syndrome. In fully awake patients, you must also take note of those patients who had mydriatic eye drops. Baka naman kasi medyo hindi nagpantay kasi may binigay kayong eye drops. You also need to take note of that. Also, for cases of picomanurism or Horner syndrome, you also need to take note. For your anisocoria, make sure also that you note if your patients have particular eye findings, if for example, post-LASIK surgery sila. Next slide, please. Aside from the pupils of the patient, we also need to make sure that we monitor their gaze deviation. What is gaze deviation? This is the movement of the eyes horizontally from left to the center and then to the right side. So you can see here from the cortical lesion, the most one at the left, if the stroke is located down on the left side, so most probably your gaze will also turn or your eyes will also turn to the left. If, for example, your stroke is in the pontine lesion or the pons, which is shown in the middle picture, most probably your eyes will go towards the left side, towards the right side. Pabaligtad naman siya. But if, for example, you are considering a stroke or a seizure, such as those in the right side of the screen, you can see that the origin of the seizure is on the left cortex. You can see that the eyes is going to the right. Magkaiba siya. So, ano ang particular na benefit nito sa ating mga nurses? So, you can see there that the for stroke occurring in the supratentorial, meaning on the higher cerebrum, kung nasan yung site na pinanggalingan ng stroke, if for example, nasa left, yung mata, papunta din siya sa left. Not unlike pag doon ka sa seizure, kung nasaan yung pupils, kunwari nasa left side yung pupils po ninyo, most probably yung seizure is galing sa right side ng hemisphere of the brain. Iba naman yung case if, for example, yung stroke is nandun sa may pons area, as you can see on the middle picture. Diba nasa left siya, pero yung mata nyo nakatingin sa right side. So parang siyang kabaligtaran. Next slide, please. So, just like what I've said earlier, we will be also discussing about herniation syndrome. So, what are herniation syndromes? So, it just says that in a layman's term, herniation means one part of the brain is going to the other side or going either upward, sideward, or downward. Nagkakaroon siya ng shifting or umuusog yung particular side ng brain. Yun yung tinatawag natin na herniation. So, we do have the different types of herniation as you can see in the screen. Most commonly, ang makikita natin sa patients, subfalcine or cingulate herniation. This means that if, for example, you have a massive stroke on the right side of the brain tissue will then move or shift towards your left side. So siya yung tinatawag natin na subfalcine. Movement from the left to the right or right to the left side of the brain. Next, we have your central transtentorial herniation, meaning the central part of the brain, if there is a stroke in this particular side, it will try to go down and cause edema downwards. We also have your uncal herniation. Uncal herniation, for this one naman, this is the part or the medial part naman ng the brain is going to the center, going downwards. Next, upward cerebellar or transtentorial herniation. For this particular type of herniation, your stroke is located in the cerebellum. So, ibig sabihin, dito siya sa baba ng cranial vault, banda dito sa may cerebellar area. So, since the cerebellum is has a much less space, its tendency is to go to a space that it can occupy. Since medyo masikip dun sa part ng cerebellum compared dun sa upper part ng brain, ang tendency niya, aakyat yung cerebellum or part of the cerebellum will go or push itself upward. So yun yung tinatawag natin na transtentorial herniation. Next, we have the tonsillar herniation. Tonsillar herniation, for this one naman, cerebellar lesions din to or stroke, but for this particular type, instead of going upward, it will go downward. So since it's going downward, it might compress your spinal cord and the different structures there. So if there are patients with cerebellar lesions, most probably your physician will order them to be monitored in an intensive care unit or a comprehensive neuro unit. Why? Because these are the patients that are prone to this particular type of herniation causing compression of your brainstem and the spinal cord. So sila yung mas prone kasi sa mga complications. Rarely, for this type of herniation syndrome, meron tayong tinatawag na transcalvarial. So this particular type only occurs if there is a skull defect. If, for example, may fracture due to a, for example naman is yung TBI, traumatic brain injury kasi na-fall. Nagkaroon ng fracture. If the hemorrhage is too big inside, the tendency is to go outside. So yun yung transcalvarial. The brain itself is going up outside of the vault. Next slide, please. We now go to the different post-operative procedures for stroke patients with hemorrhagic type of stroke. So the most common that we see is your craniotomy and craniectomy. Craniotomy. What is craniotomy? This refers to a surgical removal of the bone to expose the skull and the brain. Specialized tool, especially your bar hole, is used to remove the section of the bone, which is called a bone flap. And then this is temporarily removed and replaced after the surgery. So as you can see on the screen, from the left going to the right, the surgeon will first mark the area where he will drill the bar hole. And then the next, the bone flap will be removed. And then the last picture tells us that if, for example, they need to evacuate the hematoma inside, they will remove the blood clot and afterwards, they will bring back the bone and suture it. Next slide, please. For these particular images, we can see here a craniectomy. What is the difference between your craniotomy and craniectomy? Craniectomy is a neurosurgical procedure that involves removing a portion of your skull in order to relieve the pressure inside. So as you can see on the images, in sa scanning images natin on the left side, for the first picture, you can see there that that is the patient's scan. On the middle one, you can see there that there is a massive stroke. Massive stroke in the right side of the brain, in the frontal frontoparietal area. So the surgeon opted to remove the flap, the bone flap on that particular side, creating now your craniectomy. So the bone is the one that is colored white in the screen. It will appear white in your scan. The gray one, most probably, is your brain tissues or your tissue parenchyma. The one that is colored black inside is your ventricle. So that's the CSF. So you can see on the first imaging that there is a particular stroke on the right side of the brain. So due to the massive stroke and edema that this particular stroke presents, the physician opted to remove the bone flap and allow the patient's swelling to maximize itself for a certain period of time. So on the right side of the screen, you can see there that the edema might subsided or the edema subsided kasi nakita nyo naman nag-uka na siya, di ba? In our patients, mostly after 2 to 3 months bago yan mag-uka na ganyan. So ibig sabihin yan, from the time that they operated on the patients, you will wait for a few months para makita mo yung effect. Kasi for the first 1 to 2 weeks niyan, sigurado ako dun sa post-op site, medyo nagsiswell pa yan. Hintayin nyo lang yung months after. Mostly mga 2 to 3 months makikita nyo na yung effect niyan. Unti-unti na magsasubside yung maga kung nasan yung part na na-opera. And at the same time, kapag medyo nag-uka na siya, you might also ask your neurosurgeon if, Doc, when will be the best time that we will be able to bring back the bone flap? If, for example, your physician do place the bone flap inside through what you call a cranioplasty or a repair of the skull, this one kasi is being done for not only for your aesthetic purposes but also for protection na rin. Why did I say aesthetic purpose? It's because, aminin natin, pag nakakita ka ng isang tao na sa labas, outside na nakashrink yung particular part ng brain, may mga tao kasi na medyo natatakot, parang ganoon. Kaya one way for our post-stroke patients to gain their confidence in themselves, lalo na kung kunwari naka-recover na sila sa phase na to ng stroke, is make sure na yung appearance din nila is satisfied sila at hindi sila nagsa-self-pity. So, next slide please. For patients who have undergone your craniotomy and craniectomy, you also need to take note of the following. 1. Patients with cerebellar or posterior bleed should be considered for emergent transfer in a comprehensive stroke center. Why? Because these patients are at risk of your brainstem compression or spinal cord compression. Kasi masyadong masikip dyan sa may cerebellar, sa may posterior area, as compared with the different brain structures upward, dun sa taas ng may tentorium. Next, lesions in the posterior fossa can lead to life-threatening complications. Just like what I've said, compression of the brainstem. So what will happen if the brainstem is compressed? The other reflexes will tends to be much more abnormal. Also, malapit din dyan yung centers ng ating respiration at cardio. So if in case dyan yung tamaan ng stroke at dyan magkaroon ng particular edema, pwedeng ma-compromise yung reflexes at saka yung cardiovascular and respiratory status ng patients natin. So more prone sila mag-arrest. Next, patients with supratentorial hemorrhage more than 30 ml within 1 centimeter of the brain surface are a good area or a good candidate for this type of surgery. So if, for example, your patients are a case of a CVD bleed, one of the considerations of the neurosurgeon is where is the stroke located? Also, how much is the bleed? Because if, for example, the bleed is too much, they will not operate on it if they deem that it will only cause suffering to the patient or that it will cause further complications. Also, they would also need to make sure that the site is also considered Because if, for example, your lesion is in nearer to the midbrain, banda doon, they would weigh their options about it. Hindi katulad if, for example, nasa bandang higher brain structures yung lesions. And then cerebral edema is expected from all type of infarcts and hemorrhage, but the larger is the infarct or the larger is the hemorrhage, the larger din yung tendency na magkaroon ng cerebral edema after. Next slide, please. Patients with large strokes and infarcts or hemorrhage should be monitored in the neurocritical care unit or specialized stroke unit. Why? This is because these particular units are equipped in taking care of these patients, especially those who have a tendency to have a particular complications, such as the herniation syndromes that we cited before. Decompressive hemicraniectomy within the first 48 hours after the ictus results in better clinical outcomes and fewer mortality among malignant stroke patients. What is a malignant stroke? A malignant stroke just means that it is a stroke in either the left or the right side of the brain or in a particular territory or an artery, but it comprises of a large territory or marami siyang nasasakop na area. Most common for these malignant strokes are those strokes occurring in mid-cerebral artery. If, for example, nagkaroon ka ng stroke sa may right MCA or right mid-cerebral artery, and then yung affected part mo is your frontal, parietal, temporo-occipital area. Kumbaga, pag sinabi kasing malignant stroke, more or less, nangyari yung stroke dun sa isang site na malaki yung area na sakop. Ibig sabihin, almost 1/2 or 1/3 ng area of the brain is affected. Kaya siya tinawag na malignant stroke. And then most common of these are due to an increase in your blood pressure. Next, monitoring patients for herniation, infection, seizure, leakage of your cerebrospinal fluid, or contralateral hematoma post-operatively are of tantamount importance. So infection, how do we monitor patients for infection? If, for example, post-op si patient at nagkaroon siya ng fever, you need to inform your physician about it because they will rule out the different causes of the fever because they need to exclude the septic part. Is the patient's febrile because meron siya mga devices? Is it due to the ET tube? Is it due to the urinary catheter? Or pwede din ba din sa post-op site? Yun kasi yung dapat nating i-check. And then monitoring for seizure. Seizure post-op is not common. So you have to inform your physician if your patients had convulsions. Next slide, please. Now we go to another interesting neurosurgical intervention. This is your external ventricular drain or EVD and your ICP monitoring device. So on the left side of the screen, you can see here an EVD. This is an external ventricular drain that temporarily allows the drainage of your CSF from the ventricles, making sure that it is a closed system. Ibig sabihin po nito, since closed system siya, if the hemorrhage is nandyan sa part na yan, na nagkukos siya ng hydrocephalus sa patient, meaning hindi makalabas yung CSF dun sa mga ventricles because most probably nagkaroon ng edema, masyadong malaki yung hemorrhagic stroke na nagkaroon siya ng edema, naipit yung ventricles, kaya nagkaroon ng hydrocephalus. Pwede rin naman na yung particular hemorrhage is nasa loob mismo ng ventricles. Kasi meron tayong tinatawag na intraventricular hemorrhage. Nagkaroon siya ng stroke doon mismo sa site kung nasa yung third and fourth ventricles. So our physicians, for this particular type of surgery, they will insert a catheter, which is a temporary drain. And then as you can see in the screen, excess blood, excess CSF will go into your catheter and will go into the drain. So what is the role of nurses for this particular type of contraption? Number one, make sure that you position your EVD on the desired level of your physician. Kapag sinabi niya na ilagay mo yung EVD drain katapat ng external auditory meatus, doon mo ilagay. May mga chances din po kasi na ina-adjust ng ating mga neurosurgeon yung level ng EVD drain if they deem na kailangan ng tanggalin yung EVD drain. Yan yung tinatawag nila na EVD challenge. So what they do is they try to elevate your EVD. They will try to close the clamp and then elevate it for our particular level. And as a nurse, you will need to monitor your patients. Mas natulog ba ang pasyente? Mas hindi ba siya nagigising? Mas nagkaroon ba ng worsening ng neurodeficit? Kasi pag nagkaroon ng mga yan, immediately inform your neurosurgeon because it might tell that the particular patient is not yet deemed to have your EVD removed. Or pwede rin naman na nagkaroon siya ng particular signs and symptoms that is worsening sa case niya. Also, number 2, if for example your physician ordered for a monitoring of your EVD, you have to make sure that you also monitor it. If sinabi po niya na every 8 hours or every 12 hours mo i-drain mo siya. Kasi ang gagawin mo lang naman, ika-clamp at unclamp mo lang siya dun sa particular na stopcock niya eh. And then, number 3, if for example your physician is ordered for a particular sample of your CSF, make sure that you get your sample with the neurosurgeon or the neurosurgery resident, making sure that you do it aseptically to prevent infection. For your ICP monitoring device, that is the device that you can see on the screen on the right side. You can see there the number, the ICP itself. Yung tinatawag na 18 sa screen, yun yun. And then you can see the waveform on this particular device. So what does this tells us? This particular type of your device is a temporary device that allows measuring and recording of your intracranial pressure. This is most commonly seen sa mga comprehensive stroke centers. And I think may mga hospitals na rin dito sa atin na available yan. For example, sa may Tala Hospital dyan sa may Caloocan. And then your ICP device, it's just like you're an EVD. They will insert a particular catheter into the brain, and then it is like a para siyang central catheter, or it's like an IJ catheter na may mga ports. One port is for monitoring, which you will connect to the ICP device. One port is also dedicated for extracting the specimen, just like your external ventricular drain. And the other one is for the other port. Yan. Next slide, please. For this particular type, we have a patient who undergone an insertion of your lumbar drain. So this is a small, flexible tube inserted in your lumbar spine that drains some amount of your CSF that fills the brain. So your CSF is the one that circulates, right? In assessing the normal pressure hydrocephalus, draining your CSF for a few days is helpful in determining if your patients will benefit from a VP shunt. So, nilalagay po nila yung lumbar drain if, for example, they deem that they're trying to check if your patients ba kapag nilagay ba to, magsasubside na ba yung hydrocephalus, or they need a permanent one, which is your VP shunt. The VP shunt kasi is permanent rather than this one because your lumbar drain is also prone for your infection. Next slide, please. Ventriculoperitoneal shunt. So this particular type of procedure drains your CSF where there is an obstruction in an outflow and there is a decrease in absorption of the fluid. Your shunt are used to treat your hydrocephalus. So you can see there that there is a ventricular catheter inserted and the incision is made on the particular patients and the cavity is checked on your peritoneal cavity. So if your patients had undergone a VP shunt insertion, make sure that you also endorse it to the nursing units where you will transfer out your patients post-operatively. Because there are times that as the patient age, for example, nag-lapse na yung years. Pag bumalik si patient after 4 years, 5 years, umuusog kasi yung VP shunt eh. Kung saan siya nilagay initially, may time na kaya nagmamanifest ulit yung symptoms ng hydrocephalus, pwede pa lang dahil lumaki na si patient, nag-a-adjust din yung shunt. So they need to do a imaging scan just to make sure that the shunt is in place. So that's your role as a nurse. Make sure that if, for example, your patient had a VP shunt insertion in the past, you have to make sure that you note it in your history taking and inform your physician about it. Because pwede kasi na kaya pala niya nararanasan yung ganyang mga sintomas, meron na kasi siyang shunt before na pwedeng hindi na umaandar ulit or na nagbara na kailangan ng palitan or i-adjust yung level. Next slide, please. As nurses, we do have other interventions to control their elevated intracranial pressures. So you can see here, it's just like a ladder. So you start with the one on the left side, yung color blue. So we do have checking of your airway, breathing, and circulation. Make sure that the head of the bed is elevated to 30 degrees and the neck is at the midline position. Checking if the patient needs analgesia and sedation. Normothermia. Normothermia meaning 36.5 to 37.5 because evidence-based practices in nursing tells us that nowadays it is better to make sure that your patients who have undergone a brain injury or heart injury have a normothermia levels rather than hypothermia. It's because way back 5 to 10 years ago, the concept is lagyan mo ng maraming yelo ang pasyente. Kailangan malamig na malamig. Less than 37 degrees yung kanyang temperature dapat. But recent studies have shown that patients, when put into a hypothermia protocol, they have a more tendency to acquire complications. Complications such as shivering, nagkakaroon ng mga acidosis, na-altered yung mga electrolyte levels, pati yung sugar levels. And comparing it with your normothermia, they've seen na most likely, normothermia is preferred. Next, neck is on the midline position, meaning hindi po siya naka-flex, hindi rin siya hyperextended. And use of steroids. For your second tire, your tire 1, we have your hyperosmolar therapy. Hyperosmolar meaning you use either mannitol or if you do have your 2% or 3% sodium chloride, you use it. But make sure po that if you use a 3% sodium chloride, you administer it via central line. Why? Because it's too toxic to the vessels that it might cause extravasation and infiltration. Transient hyperventilation. So this means that you will going to ambubag your patients for at least mga 15 minutes just to relieve the excess CO2. Next, CSF drainage and consider surgical decompression. For your tire 2, the one on the green or the olive color, make sure that you elevate your targets for decompression. You optimize your sedation and analgesia, and do rescue decompressive surgery. For the last one, tire 3, if these particular interventions are not effective, you might consider induced coma, meaning, ano bang induced coma? Induced coma is your making sure that your patients during the acute phase of the stroke, if it is too big, you have to give them medications such as your propofol, fentanyl, or midazolam to knock them out because your goal is to make sure that they are GCS3, meaning knock out lahat ng sensorium for the meantime. So you will just do a holiday sedation maybe after 2 days or 3 days. You will turn off or decrease the sedation and check the neurostatus of the patients. But for the meantime, for this particular time after up to a certain time that the physician has ordered, you will prophylactically induce coma. You will do a prophylactic coma for the patients. And then therapeutic hypothermia. If for example, hindi siya if the patient is not particularly efficient dun sa particular na yan, meron din tayong tinatawag na mga hypothermic protocols. Although just like I said, you have to weigh with your physician, is it going to be a hypothermia protocol or a normothermia protocol? Next slide, please. What are the do's and don'ts for neurosurgical patients? So these are the things that we need to avoid. Avoid hypoxia, meaning your target autosaturation should be at least 94% and above. Because if, for example, the body needs a particular autosat of 94, but the brain needs more oxygen than the other parts of the body. That's why we need to make sure that the autosat of our patients are higher compared with the normal ones. Avoid hypotension, meaning make sure that your patients does not have a BP less than 100 systolic. For that particular target, you might ask your physician about it, but from the patients that we do have, most commonly the physicians might order at least 120 systolic BP. And then others, avoid severe hypertension and severe hyperglycemia. Why was hyperglycemia mentioned here? It's because they have found out that stroke patients with hyperglycemia has a tendency to have more complications afterwards. They also see a high mortality rate for patients with uncontrolled hyperglycemic states, especially those with CBG of 300, 400 and above that are uncontrolled for how many days? Because that is detrimental for your stroke clinical outcomes afterwards, even after your patient was discharged. Next, reduce noxious stimulation such as your noise. If your patients are post-operatively, most probably they need a quiet environment. So please make sure that your units are not prone to noise. Huwag masyadong maingay kasi po, paano magpapahinga yung pasyente natin kung lahat ng tao sa station maingay? Hindi po kasi sila makakatulog. At kapag hindi sila nakatulog, mas prone po sila sa delirium. Yung tinatawag natin ng mga nagkakaroon sila mga confusion, nadidisorient sila sa date and time, kasi nga hindi sila nakakatulog. Imagine mo na opera ka, tapos ang ingay ng mga tao sa station, yung hindi ka makatulog ba for several nights, malaki kasing effect niya both sa vital signs as well as with the other physiologic parameters ng pasyente. Next, provide sedation and analgesia to target. Just like what we said in the tire before, if the patients need to be in an induced coma, you ask your physician about it because they will set the target for it. Ano ba yung sedation na kailangan natin? Is it a deep sedation? Is it a moderate one? Or just a mild sedative? Next, maintain normothermia, euglycemia, and euvolemia. Euvolemia meaning when you monitor your input and output, make sure that the urine output is not less than 30 ml per hour, which is vital for your kidneys, and also not exceeding 200 ml per hour for the next consecutive hours. Because if the patient do have a consistent more than 200 ml per hour output for the past 3 to 4 hours, then you need to refer because your patient might be having symptoms pertaining to your pituitary gland. Next slide, please. Positioning of the head. Why is head positioning very important for stroke patients? It is because, as you can see in the picture, if your patient is not properly positioned in the bed, meaning, for example, the patient is post-op and then you position your patient in a Trendelenburg position, tingin nyo, magkakaroon ba ng enough na jugular vein pressure yung patient para ma-perfuse yung oxygen? No. What naman ang mangyayari if, for example, your patient is flexed, yung parang ganito, or hyperflex, yung ganon. Ang nangyayari po kasi dyan, naiipit yung daluyan ng dugo. Pag naipit ang daluyan ng dugo mula dun sa abdominal cavity, thoracic cavity, paakyat ng jugular vein ninyo, yung nandito sa carotid. Kasi pag nakaganyan kayo, naiipit siya dito eh. Eh di ba nga yung pasyente po natin mayroong stroke, hemorrhagic type of stroke. Meron din siyang post-op surgery. Mas less yung napupuntang oxygen dun sa brain dahil lang mali yung pagposisyon natin sa pasyente. So make sure that when you position your patient 30 degrees, the head is at the midline because it improves your venous outflow. Also, if your patient has a VP shunt, an EVD, you consult your neurosurgeon about it. What is your target head elevation? Because they may have a rationale for it. Next slide, please. Turning and position. For patients who have undergone craniectomy or craniotomy, there is no restriction for your positioning. You can position them on the left side, right side, but make sure that you monitor the site of the surgery. And you place a caution there that there is a no bone flap or right skull precaution. Ganon. Para lang ma-make sure na may particular na monitoring kayo dun sa site na na-opera. Para at least, if for example, itagilig nyo man siya din sa right side ng bed, careful pa rin kayo na hindi magkaroon ng pressure dun sa site na na-opera. And then regular bed turning can reduce your pressure sore formation. Remember, it would take 2 hours of tissue ischemia in order to develop a stage 1 pressure injury. So stage 1 pressure injury, yan yung redness na hindi nawawala kahit pisilin mo ang balat ng pasyente. Also, you need to avoid extreme flexion of the neck that will reduce your cerebral blood flow. Next slide, please. Now we will be discussing the delirium, agitation, and their connotations of prolonging the ICU stay. Presence of pain, catheters, tubes and monitors, limited mobility of the patient, inability to communicate with their loved ones and with the nurses and doctors, sleep deprivation in the intensive care unit, excessive lighting, and frequent monitoring all sum up to the following. Lahat po siya nagkukos ng delirium, agitation, and prolonged ICU stay. So, I would like also to share with you that my study is about how the vital signs are affected with just particular the presence of the following on the left side. So, share ko na din po sa inyo para at least ma-update din kayo na meron palang ganitong mga nangyayari. So, my study is about the relationship of your noise, light, and interruption frequency among the mechanically ventilated patients in an intensive care unit. So I chose the neurocritical care unit. Why? Because these are the patients who are catering to level 4 patients, meaning they're highly ventilated, they're unresponsive, they're comatose, more or less they are helpless. So the nurses are the one who will be empowered to do so, to take care of them. So the study have resulted into the following. So number one, we have found out that patients, the more the nurse goes into the intensive care unit cubicle, di ba meron tayong tinatawag na every hour monitoring? So aside sa every hour monitoring, syempre papasok ka pa rin sa pasyente natin. The more is the chance that you go inside the room, the more is the chance din na hindi sila nakakatulog kasi nade-disturb sila, the more chance na tumataas yung heart rate ng pasyente. And then the more chance na tumataas din yung BP kahit mga 2 to 3 millimeters of mercury lang. So, the study had also shown that the more frequent the nurse interrupts the patient, say 6 times in 1 hour or more, parang every 5 to 10 minutes nag-visit ka sa pasyente tapos may ginagawang kung ano-ano, the more na nadi-disturb sila, the more na nagtataasan yung mga vital signs. So what is my recommendation? Make sure that you do a cluster care monitoring. What is that? Cluster care monitoring is beneficial for ICU patients. Since if, for example, you know already that it is already 9 o'clock or it is already 10 o'clock mamaya, i-cluster mo na lahat ng pwede mong gawin inside your patients para makapagpahinga yung pasyente. Also, in the study, di ba meron ditong tinatawag na sleep disruption due to excessive lighting and excessive activity. We have found out that in a normal intensive care unit, the minimum decibel that you have is at least 70 to 90 decibels, which is abruptly not within the recommended guidelines of the World Health Organization for a hospital. Because the recommended one is at least 35 to 40 decibels lamang po. So in short, maingay. So ano ang kailangan natin gawin? I-improve natin yung mga workplace environment natin para makapagpahinga yung mga pasyente nating na-opera, lalo na yung mga pasyenteng may stroke. Kasi po, sila yung mga most probably due to your sleep deprivation, presence of pain, presence of frequent interruptions from the nurses, they will have in the future agitation. Kita nyo, sila yung madalas nagkakaroon ng MEC-VENT asynchrony. Most probably, they are the ones who are confused pag chinek mo yung mga sensorium nila. And mas prolong sila magstay sa ICU. Our goal as critical care nurses is to make sure that we do our tasks diligently and we shorten their stay in the intensive care unit or to the stroke areas para mas mabilis po nila makasama yung mga relative at mahal nila sa buhay. Next slide, please. Aside from the other interventions, I cited here pain management. So these are the most common analgesics that we give to our patients. Paracetamol IV, the maximum dose for this one is at least 4 grams per day. So if you see that your physician have ordered a paracetamol 1 gram IV Q6, and then nag-order pa rin siya ng paracetamol 300 milligrams PRN every 4 to 6 hours for fever, you might want to question the order of the physician by asking it diligently and professionally. So you might say, Doc, maybe we need to discontinue your PRN dose of your paracetamol because it is beyond the expected maximum dose for this particular type of patient. And then you also administer your NSAIDs such as your tramadol. For this one naman, the most common side effect that we see in our patients is nagkakaroon sila ng vomiting, nasusuka pag yan yung binibigay namin. And then for your fentanyl, I think this one is mostly preferred, especially if your patients have acute pain na hindi nawawala with your paracetamol. Because mas madali siyang ma-assess later afterwards. Also, you need to assess the surgical dressing of the patient. Is it too tight? Kasi kung masyadong masikip po yung pagkapacking ni Doc, medyo irritable yung pasyente dyan afterwards. You also need to make sure that you assess your patient's pain score and you provide your round-the-clock po na paracetamol. Next slide, please. So in the intensive care unit, what are the different tools that we use to assess our pain score? So aside from the numerical score, yung tinatawag natin na yung nag-i-score tayo ng 1 to 10, 0 meaning no pain, 10 meaning the worst type of pain. For patients who are ventilated, we will use a critical care pain observation tool. So for this particular type, it includes your clinical indicators such as the facial expression of your patient. Is the patient frowning, grimacing, or relaxed? The body movements of the patient. Is the patient relaxed, cautious, or meaning nagkakaroon siya ng mga tendency to protect the limbs, or nagpo-pull out ba siya ng mga tube na kailangan siyang i-restrain? Also, the muscle tension, compliance with the ventilator, nagkakaroon ba ng vent asynchrony, tunog ng tunog ang mga respirator. Kasi pala, gising yung pasyente mo. Bakit gising? Kasi pala, may masakit sa na-opera sa kanya. Pero hindi niya masabi kasi nga, meron po siyang EP tube. Next, vocalization. So if you sum it up, there is a score of 10. So for your CC pot, any score of 2 and above means that your patient has pain, and this needs to be addressed properly and referred to your physician. Next slide, please. For patients po with your presence of restlessness, yung mga aligagang pasyente na galaw ng galaw, na hindi mapirme sa kanilang mga kama, lalo na at kaka-opera lang nila, make sure that you also assess their agitation and sedation skill. For this one, I cited here your Richmond Agitation Sedation Scale, RAS. Maganda yung gamitin. Meron din tinatawag na Ramsey scoring. Pero sa amin kasi, we found this one much more aligned and effective with the use of your CPOT. So when the patient is restless, you might ask your physician, Doc, since we will be starting a particular sedatives for your patients, what is your particular sedation scoring target? O diba? Na-impress nyo na yung doktor, meron pa kayong tinatawag na confidence as a nurse. So, pag sinabi ni Doc na ang goal natin is 0, alam mo na automatic, ang ibig sabihin ng yung pasyente dapat kalmado. Or ang goal natin, since your patient has a severe type of stroke, I wish to have a target of -5 in your agitation scoring. Pag ganun yung in-order sa chart, syempre kapag hindi mo alam kung ano yung sinasabi ni Doc, hindi mo alam anong gagawin mo. So better for us to understand this particular skill. So kapag sinabi pong -5, ibig pong sabihin yan is the patient is unarousable. Ibig sabihin GCS3 siya. Pharmacologically sedated and comatose. Yun. If your score is -4, deep sedative yan. So no response to the voice but with movement to physical stimulation. For example, nag-elicit ka ng pain sa nail bed, either gagalaw yung isang kamay or parehong kamay. Moderate sedation is any movement to the voice. If for example, nag-whisper ka ng Mr. Ganire-ganire, naririnig niyo po ba ako? Tapos biglang lumingon si patient kahit nakasara ang mata. -3 ang score mo doon. -2 naman is your light sedation. Ibig pong sabihin yan, kinausap mo si patient, Mr. ganito-ganito, kaya po bang imulat ang inyong mga mata? Nag-open siya ng eyes pero less than 10 seconds, pumikit na ulit. That is light sedation. Ang drowsy naman po or -1, this is not fully alert but the patient has sustained eye opening of more than 10 seconds. Your sedation goal might vary depending on the case of your patient. So it is better to ask your neurologist or your neurosurgeon about your target sedation score. And then, as you can see from the scale, 0 is calm. The more negative it goes or the more negative it goes, the more sedative is being given to the patient, kaya mas knockout siya. The more na mag-positive siya, as you can see, +1, +2, +3, +4, the more na magwawala siya. So, for our post-op patients, most probably ang goal natin yun yung 0, pababa, papunta din sa negative part. Kasi pag ang patient nagkaroon ng mga +1, +2, i-assess mo na bakit siya agitated. And ang ayaw nyo po kasi dyan yung +4, combative. Ibig sabihin, yung pasyente is high risk po for self-injury, pwedeng matanggal niya yung mga contraptions. Kung mayroon siyang EVD, matanggal niya yung EVP. Or pwede rin matanggal niya yung ET tube natin kung siya ay ventilated. Or pwede rin na dahil sa kalikutan niya, malaglag siya sa kama. Or high risk for fall. Yan yung mga ayaw nating mangyari sa ating mga pasyenteng na opera. Next slide, please. Also, you need to monitor the patient's input and output. So just like what I've said, fluid balance makes a vital role in monitoring the clinical outcome of the patient. Depending on the case of the patient, you will target a specific fluid balance. If, for example, your patient is ventilated, a fluid balance of +1,000 might seem to be okay because meron tayong tinatawag na sensible loss due to the ventilator. But if, for example, your patient is not ventilated but post-op, and then nagkaroon siya ng fluid balance of +3,000 in 24 hours, dapat lang i-refer nyo na po yan sa doktor kasi hindi yan normal. Kasi makikita mo na agad sa trend pa lang ng 8 hours na bakit sa akin 8 hours pa lang pero positive 1,000 na. So ibig sabihin maraming naiipon na tubig. Huwag niyo na pong paabutin yung 24 hours pag ganun yung trend ng fluid balance output po ninyo sa pasyente. Kasi most probably, meron na yung nangyayaring onset ng other sintomas ng ibang sakit or pwede ring post-op complications. In the screen, we will be discussing about your SIADH as well as your other types of imbalances. Next slide, please. For your airway management, this just says that if your patients need to be intubated right away, either pre-op as prophylaxis or post-op, they need to be intubated. And we need to make sure that we suction our patients appropriately. So suctioning naman our patients does not require naman any doctor's order. It is an independent nursing intervention. If, for example, your patients come in post-op, CVD bleed, and your patients has been coughing kasi may nakita kang copious secretion, suction it. Kailangan kasi maprotektahan mo yung airway ng pasyente natin. Also, make sure that you clean handling of the ET tubes and suction catheters if, for example, you will be assisting in a prophylactic intubation of the patient, just like what is shown in the screen. Also, you need to assess patients if they are at high risk of developing airway obstruction. What do we mean when we say prophylactic intubation? This is done if in case your patients have been makikita na doc na, for example, sa assessment niya is hindi na nagigising sa patient. So decreasing in sensorium might be one. Presence of secretions na hindi matanggal-tanggal kahit gumamit ka ng mga oral airway na andun pa rin sa bagal. No? That's also one. Prophylactic meaning you will intubate the patients to prevent further complications afterward. Next slide, please. DVT prophylaxis. So for your deep vein thrombosis prophylaxis, these are the following interventions that you might want to consider as a nurse. So you may inquire with your physician, Doc, do our post-op patient needs an anti-embolic stockings or an intermittent pneumatic compression device? Which is the difference of these two? The one on your right, the one on the left side with the color green outline, yung may green na outlining po na para naka-flex yung knees, yan yung tinatawag na anti-embolic stockings. Pwede nyo rin po yung ilagay if, for example, your patient does not have a DVT. Kumbaga, wala ka nakita na venous clot during your venous compression study. But if, for example, si patients naman po is meron po siyang tinatawag na DVT, yan po pala yung mas preferred. If, for example naman, yung nasa baba, yung the one with the machine, this is your intermittent pneumatic compression device, or in other terms, it's called also a sequential compression device, CSD. This one is being given for patients who have no DVT. Ayan. No DVT, klaruhin natin ha. If, for example, nag-order si Doc ng venous compression test, nakita sa pasyente na wala siyang DVT sa paa, yan po ang ilalagay nyo. Kasi yan, nagko-compress yan ng hangin every at least every a few seconds or minutes. Pero kapag ang pasyente ay may venous clot sa paa, tanggalin nyo po or ipa-order nyo kay Doc yung pag-off ng sequential compression device. If, for example, meron na siyang ganyang device tapos nagpa-venous scan after a few days, may nakita na positive for DVT, i-off nyo po agad yung device at ipa-order nyo sa doc na i-discontinue yung ITC. Because pag umaandar po kasi yan, prone na yung clot dyan sa leg mag-throw sa ibang organs. Pwedeng sa kidney, pag minala, sa heart, tsaka dyan po sa brain. So anong i-offer natin if, for example, nagpa-venous scan and then nakita na merong clot, yung nasa taas, pwede. Yung tinatawag natin na anti-embolic stockings. Ang ibang tawag din sa kanya is TED stockings or compression stockings. As nurses, if for example, you're going to apply an anti-embolic stockings, you need to make sure that you know how to properly measure it. You check for the calf circumference, the diameter po niya, at yung leg circumference. Also, make sure na pag turn kayo every 2 hours, isama nyo na po sa chine-check po ninyo yung anti-embolic stockings. Kasi may mga pasyente na hindi hiyang sa stockings, kaya ang nangyayari is nagsusugat po sila, nagkakaroon sila ng mga venous ulcers. Or yung iba, sugat talaga na pressure sore or pressure injury. Also, the physician might also include other medications for your DVT prophylaxis. We can see here presence of your NOACs or your novel oral anticoagulants such as your apixaban or Eliquis. The doctor might also give aspirin or low molecular weight heparin. Most commonly, we use enoxaparin or dito sa example natin, Clexane. Next slide, please. So, we are nearing the end of our lecture. But before we end, we also need to make sure that our patients do not suffer from infection or post-operative complications due to sepsis. So most commonly, these are the ones that we see in our patients. CAUT or catheter-associated urinary tract infection due to the Foley catheter, CLABSI or central line-associated bloodstream infection, or this one is seen in your central line, IJ, FEMCAT, subclavian, PICC line, and then VAP, ventilator-associated pneumonia, if your patients do have your ET tubes. And then, since patients is post-neurosurgical, surgical site infection or SSI. You can see in the screen the 5 moments of hand hygiene. So when do you do hand hygiene? Pwede siyang through the use of your hand rub with an alcohol or pwede hand washing sa mismong lavatory or sink. So you can see here the 1, 2, 3, 4, 5. 5 moments before touching the patient, before doing a clean or aseptic procedure, after exposure with the body fluids, after touching your patient, and after touching the patient's surroundings. Why is hand hygiene very important? Because hand hygiene is the most significant and very important tool in reducing the risk of hospital-acquired infections. Next slide, please. As you can see on the screen, so this one is an interventional patient hygiene shown by the critical care nurses also abroad. So you can see here the role of hand hygiene. Siya yung pinakagitna. As you can see, yung pinaka-green na nasa gitna, na pinakamalaki. Kapag nag-hand hygiene ka at nag-oral care ka sa pasyente, mababawas mo yung VAP. Pag nag-hand hygiene ka at nagbigay ka ng tama at appropriate na catheter care sa Foley cat, maiiwasan mo ang CAUT. If mag-hand hygiene ka, magdagdag ka pa ng gloves, maggawa ka ng skin care, bathing, paliguan mo yung pasyente, mababawasan mo yung CLABSI, surgical site infection, hospital-acquired skin injury. Ibig sabihin, nandyan yung mga bed sore, pressure injury, medical advice-related skin injury, incontinence-associated dermatitis, andyan sila lahat. And mababawas mo rin yung fall. Next slide, please. So for your CLABSI, we cited here the evidence-based practices that are now at trend in the other regions of the world. So bukod sa hand hygiene, maximum barrier, meaning after mo mag-hand hygiene, maglagay ka ng sterile drape. If for example, maglilinis ka ng central line, maglagay ka din ng proper alcohol preparation and use of your chlorhexidine dressing. And nowadays, they use the subclavian. It's a high level of evidence because there is a 2 times risk of infection with your IJ compared with your subclavian. Next slide, please. Bathing. If, for example, you are going to render post-operative bed bath to a patient who had undergone hemicraniectomy, will you use just a soap and water versus using it with a preferred chlorhexidine impregnated towel? Ayan, as you can see on the screen, one example is the use of chlorhexidine washcloth, Clinel. Ayan. You can see on the graph on the left side, the first graph shows that they used a chlorhexidine washcloth. Yung nandun naman sa pangalawang graph, they used a towel, just soap and towel. What they found out is that mas marami po yung natatanggal na bakterya kapag paulit-ulit mong ginagamit yung chlorhexidine na washcloth compared with your regular tap water and soap. Yun. So, next slide please. Biofilm formation. What happens in our skin if, for example, we do not do hand hygiene? So you can see here at the 12R on the first column, konti pa lang yung bacteria. After 18 hours, medyo dumami na yung bacteria. After 1 day na hindi ka maghugas ng kamay, ayan, ganyan po kadami yung mga bacteria natin, mas dumami. And then dagdagan mo pa ng 6 hours, 30th hour, parang sinakop na ng bacteria yung buong area, surface area ng particular skin. So this particular slide only shows us that even if we don't do anything, bacteria multiplies by itself. Why? Because yun yung nature po nila eh. Dumadami sila ng dumadami. Kasi gusto nila yung mga areas na moist, lalo na. Ano po ba yung moist na area sa ating mga nurses? Kamay. Kamay kasi yan yung ginagamit natin pag nagbe-BEFBA. Yan ang ginagamit natin pag nagbibigay ng gamot sa mga pasyenteng na stroke. Yan ang ginagamit natin pag naggagawa ng mga nursing care. So ang take home natin dyan, maghugas po ng kamay as much as we can before and after doing our activities with our patients. So we have to do and practice the 5 moments of hand hygiene. Next slide, please. So thank you very much for your kind attention again from our organization, from the Critical Care Nurses Association of the Philippines, Delex Pharmacy and Philippine Neurocritical Care Society. I do hope that you enjoy our topic for our World Stroke Day and you continue to take care of our stroke patients, especially those with CVD bleed and post-op patients. Thank you and God bless.
Thank you, Mr. Jason, for that very comprehensive presentation. May I request you to remain on screen as we answer some inquiries from our participants. For those who have questions or clarifications, kindly send your questions through the Q&A box or in the Q&A box. While waiting for our participants to key in their questions, I would just like to ask you, Mr. Dison, you mentioned in your presentation specialization. No? Can you expound more on how in your institution the nurses can be categorized as specialized in the field of neurocritical care?
Good morning po, Sir JC. So
Morning.
currently with the institution that I am with, we do have a clinical ladder that is they're still piloting right now. But for the specific specialization as a neuro nurse or a stroke nurse, I think they are aligning it with the other organizations, especially with the PRC. So I'm not yet quite sure kung paano yung applications for that one, because I do think with the other org kasi that I have with the Neurocritical Care Society, what we have is aligned with the sa US kasi. So applications as a stroke certified nurse or a certification as a neuro nurse, yung CNRN na tinatawag. So for us po here, wala pa siyang particularly certification for a NCCU nurse or a stroke nurse. Yeah, that I've heard of. But I think they're working on it because our goal is to make sure that here in the Philippines, mag-align din tayo abroad in a way na magkaroon ng mga certifications for nurses kasi very important po yun para at least mas tutok sila sa kagaya natin, stroke care at critical care nurses.
So let me recap. So there is the SERN. Unfortunately, ano siya, international siya, pero can be used in our setting naman.
Yeah, I think
All right.
yes.
Okay. Next question, sir. You've mentioned in your presentation the different ICP levels. Is there a way that a nurse can differentiate the compensation levels by just looking at the signs and symptoms? And how should we address this?
If clinically the patients do not have an ICP monitor, so you will depend mostly on the signs and symptoms of our patients. And then when you go back to the lectures, if you are a keen observer and you also saw the early signs and symptoms, dun pa lang kasi magtataka ka na eh. Bakit kaya ang pasyente ko nagsuka, tapos projectile vomiting pa? And then after 5 minutes, biglang natulog. Dun pa lang kasi parang mapapaisip ka na eh, maybe there's something going on with the patient. So that particular question might prompt you to refer it immediately to your physician because that's a beginning sign of herniation and elevated ICP, especially if you do not have the ICP monitoring device. Because aminin po natin, medyo hindi lahat kasi ng ospital may ICP device eh, na kita niya agad na from 5 to 10 na millimeters or centimeters of water biglang mag-jump ng 30 after a few minutes. So if you don't have the device, you will just make sure that you do an appropriate nursing assessment because that is very important. Properly assessing the patient and immediately referring it to the physician.
So, proper assessment and keen eye. Okay.
Yes.
Noted on that, sir. With regards to the device that you've mentioned, do we have a more of a traditional device or the traditional method on how we measure ICP? Kasi ang nakita ko sa slides nyo, sir, is the machine.
Yeah, the
Do we
machine.
have, meron bang traditional method using a manometer or such?
Oh, I had an experience also with my experience with in the province po. Okay lang ba i-share ko? Sa province kasi to. I think it was 2 years ago. Wala sila dong ICP monitoring device but in the regional hospital, what they use nung nakita ko kasi parang nag-tour ako andun kasi yung tito ko eh. They have the EVD, the external ventricular drain, and then may inattach yung neurosurgeon na parang manometer. So I'm just not sure if that is the most accurate ba kasi wala yung device. Pero based on the clinical manifestations ng patient, nung in-explain naman niya, parang mukha naman silang pantay. Nagtutugma yung reading dun sa manometer plus dun sa clinical setting ng pasyente.
Okay, thank you for sharing your experience with that, sir. Ano pa bang may tanong? Can you share some best practices that you've experienced or noticed in handling post-operative hemorrhagic patients to avoid complications?
If, for example, the patients do have a unexpected complications, most commonly kasi na nakikita namin for CVD bleed na post-op is presence of agitation and pain. So if, for example, your patients are beginning to be more awake, you have to make sure that you appropriately score their agitation score as well as their pain score and address them immediately. Kasi the more that you do not check that particular aspect, yung for example, dinedma ni nurse, yung pasyente medyo galaw ng galaw. Kasi akala niya, yung pasyente naman to, ang likot-likot. Pero hindi mo pala napapansin, kaya siya malikot kasi may masakit sa kanya. Hindi naman siya makapagsalita. So, the more kasi na naging agitated sila, as you can see on the sedation score, the more na nagpa-positive 4 siya eh. What happens if your patient is on the positive 4 sa RASC? Combative na sila. hindi mo na sila ganun ka makuha yung atensyon nila kasi yung mind nila nakaano na ay nako, gusto ko magwala kasi may masakit, gusto ko magtanggal ng kung ano-ano. Hindi na sila makikinig sa iyo. So the best part is to address immediately what you see in the patient's post-op. Because once you address it, the less chance na mag-develop yan into complications such as unwanted pain and unnecessary agitation and sedation. O di at least kung kunwari na-address mo na yan immediately, hindi mo na isi-sedate or dadagdagan yung sedatives niya or i-adjust si propofol, fentanyl, midazolam. O diba? Mas mabilis mo pang makita yung progress ni patient. Kasi kung awake na siya at conscious after a few days, the more chances after a few days niyan, matatanggal na yan sa NCC or IC. Ilalipat mo na siya palabas. Kasi ang goal mo, the less length of stay in the hospital, the better.
So again, assessment, proper assessment, monitoring of pain level through the critical care pain observation tool. I believe meron siyang pang intubated and non-intubated.
Yes,
And agitation scoring tool.
Yes.
All right, thank you. For our last question here, this is a challenge kasi in handling stroke patients, specifically post-op hemorrhagic stroke. Do they transition to minimally conscious state, or may mga instances na nagla-lock-in syndrome sila? Kailan nangyayari yun, sir?
We do have a few cases din na nagla-lock-in syndrome, especially if yung case ng patients, siguro depende din sa case ng patient tsaka kung gaano kalaki yung stroke at yung site na affected. Kasi when you check din kasi with stroke itself, either the ischemic or the hemorrhagic, what will you consider kasi is number one, the location of the stroke. The more na papunta siya sa bandang brainstem midbrain, the less likely hindi siya gagalawin ng neurosurgeon. So most probably medical management lang yan. And then the more din the malaki yung lesions, most chances are yun yung pasyenteng baka hindi mag-survive or mataas yung chance ng morbidity or mas marami yung chance ng complication or kagaya ng sinabi mo, pwede siyang mag-lead sa ganyang syndrome. Hindi naman porket hindi mo binigay yung lahat is failed yung management. Most probably, you gave it your best, but siguro hanggang dun lang yung kaya ng medical at neurosurgical part.
Okay. Thank you. So it's all about the placement, no, kung saan talaga nag-stroke yung patient. Kasi meron mga ibang mindset na after craniotomy, ika nga gulay na yan, no, vegetative. So hindi pala lahat. Okay. Thank you, sir. Thank you. So with that, again, thank you, Mr. Dizon. I know you're busy and I know you're on duty. So let me award your certificate. So the certificate states that the Critical Care Nurses Association of the Philippines are incorporated and the Philippine Neurocritical Care Society award the certificate of appreciation to Mark Angel M. Dizon for being our speaker on the topic World Stroke Day, a closer look in the post-op care of hemorrhagic stroke during World Stroke Day. Conducted October 28, 2022, signed by the President of PNCS, Geraldine Siena, Dr. Mariano, and the President of CCNAPI, Maria Isabelita Sirogado. Thank you again, Mr. Dizon.
Thank you.
Before we continue with our second topic, let's have a quick break. We will resume our program after 5 minutes.
ICU setting. Your prescription doesn't just save lives, but they transform lives to our CSR program. How the powerful antioxidant selenium works with vitamins A, C, and E. Vitamins A, C, E, and glutathione are major antioxidants that stop the formation and buildup of free radicals that can cause chronic diseases. For the vitamins A, C, E, and glutathione to exert their full antioxidant activities, selenium is needed. Selenium enhances the absorption of vitamins E, A, and glutathione. In addition, it regenerates and strengthens the effect of vitamin C in the body. Studies show that the combination of vitamins A, C, E, and selenium enhances the immune response of the body against infections and viruses. The activities of selenium, vitamin C, and E in the body are interconnected, and the deficiency of one of these nutrients will have an influence to the others. For instance, selenium and vitamin E may mutually compensate deficiency of each other and act synergistically to slow down formation of cancer cells.
Okay, let's resume our program. For our second topic will tackle how the management of post-stroke complications, or how we manage post-stroke complications. So allow me to introduce our second speaker. He took his degree in medicine at the University of the Philippines, Manila, 2013. He had his fellowship in stroke and vascular neurology in the Philippine General Hospital and had his clinical rotation for stroke and neurovascular care at Ken and Ruth Davis Center, Northwestern Medical Center, Chicago, Illinois, USA. He also took part in several researches, and one of which was awarded first place by the Philippine Neurological Association in 2019, entitled Safety and Efficacy of Tenetaplase versus Alteplase for Hyperacute Ischemic Stroke, a meta-analysis of 5 randomized controlled trials where he is the principal investigator. Our speaker is a certified emergency neurological life support instructor and received his brain death certification from Neurocritical Care Society. He is presently connected with Philippine Neurological Association as a fellow, junior member of the American Academy of Neurology, and a member of various neurocritical care organizations. Currently, he is affiliated with St. Luke's Medical Center, Quezon City, as a neurocritical care intensivist. Help me virtually welcome Dr. Jose Miguel Medrano. Dr. Medrano, the screen is yours.
Thank you very much for that very kind introduction, Sir JC. So I've been given the
Doc,
very
Doc
yes.
Medrano, sorry, we can see that your next slide in your notes,
Oh,
your
sorry.
presenter's view.
All right.
I think you shared your screen instead of the PowerPoint.
Yes, I'll share the power. Yes. All right. Okay. All right. So again, good morning, everyone. I have the very daunting task of following Sir McCoy Dizon, a person who's dedicated his life to really improving the outcomes of neurocritically ill patients. And in much the same way, the World Stroke Days theme is living a healthy life after and before a stroke occurs. And one of the most important things that we'll be discussing to improve this healthy life after stroke is to manage and prevent post-stroke complications. However, of course, we cannot treat or manage problems that we ourselves do not recognize. So the goal of my talk really is to enhance everyone's knowledge on this topic. So I have no financial or academically relevant conflicts of interest for this topic. And here are my objectives. So I want everyone who's listening to this particular talk to understand the pathophysiology and natural history of hemorrhagic stroke, our main topic, and to be able to enumerate and name many of the post-stroke complications and demonstrate practical knowledge and skills in preventing or treating these post-stroke complications. Our primary goals in stroke care are twofold. The first being to minimize brain injury and the secondary effects of stroke. So this requires a very rapid response to stroke recognition and treatment, and to be able to understand the risk factors involved that are very important in contributing to secondary stroke injury due to as a secondary neuronal injury. Our second component for stroke care is to really improve our patients' functional recovery. And in order for us to do this well, we have to prevent the post-stroke complications that impair morbidity and functionality of our patients after developing a stroke. So in the continuum of stroke care, the addressing of these post-stroke complications is in the domain of secondary stroke prevention and stroke rehabilitation. And the members of the team who are active in preventing these complications is essentially still everyone, from the acute care team, including the physicians, nurses, the physiotherapists or rehab specialists, the dietitians, the allied health professionals, including the patient themselves, their family, and their caregivers, and your capacity for long-term outpatient care, whether it requires any private, social, or palliative care components. And all of these things require a very healthy healthcare system. So ideally, we have better support from the government and local government units in order for us to better address the needs of our stroke patients. So every single person in this entire web of people has an essential role to play in improving stroke outcomes. Since our primary topic today is really managing the complications of hemorrhagic stroke, let us have a brief review of what this is, its pathophysiology, and the natural history of the condition. So in general, we have two major types of stroke, ischemic and hemorrhagic. And while many documentation, many research states that around only 10 to 15% of strokes are hemorrhagic, in the Filipino and most Asian populations, it's actually much higher than that, reaching up to even 30 or 35% of all forms of stroke. And that's largely because we have very different risk factors from our Caucasian counterparts. So that's why we have a very high incidence of hemorrhagic stroke. And hemorrhagic stroke is simply a stroke resulting from the rupture of a vessel within the cranial cavity, whether that's from a ruptured aneurysm causing subarachnoid hemorrhage, or rupturing of a small vessel within the brain parenchyma, leading to blood forming within the matter of the brain itself. And that's what we call intracerebral hemorrhage. And for this particular talk, we'll be primarily focusing on intracerebral hemorrhage, as that is the more common condition. So how often does hemorrhagic stroke occur? So in low to medium income countries, it occurs in around 22 per 100,000 every year. And these incidence rates are actually increasing in countries that have low to middle income because of a dual burden of a poor lifestyle and of increased climate-related problems such as air pollution. So more and more younger people in our country, for example, have higher rates of hypertension, sleep disordered breathing, diabetes, and all of that leads to a greater incidence for hemorrhagic stroke. And unfortunately, hemorrhagic stroke has a greater case fatality rate, reaching around 40% at 1 month in Asian countries and 54% at 1 year in Asian countries as well. Keep in mind that majority of these case fatalities occur in more elderly patients. However, on the bright side, around 20 to 40% of this population will make a good functional recovery at 6 months. And typically, what increases your chance for a good recovery is if you're younger, if you have less illnesses prior to developing a stroke, if you're able to address all of the stroke risk factors that you had previously, and of course, the stroke severity at baseline. So these are the clinical presentations of intracerebral hemorrhage. I will not go into these in great detail any longer, but sufficing to say, there has to be a focal neurological deficit and evidence of increased intracranial pressure, which may manifest as headache, nausea, or vomiting, a decreased wakefulness, or an elevated blood pressure that is persistent. So as members of the healthcare team, whenever we see a patient with intracerebral hemorrhage, it's very important for us to note the time of onset, the vascular risk factors of the patient, especially if they have a history of previous stroke, whether it's ischemic or hemorrhagic, the medications that they are taking, especially antithrombotics and anticoagulants, any antihypertensives that they took prior or previously, the presence of any cognitive impairment or dementia, a history of substance abuse, or other diseases that may lead to a worse presentation of intracerebral hemorrhage, such as malignancy, liver disease, or uremia, which worsens bleeding in general. So when we talk about the natural history of intracerebral hemorrhage, there have been many systems that have been proposed, with the most popular being the one from Rincon and Mayer. And they break down the events of ICH into 4 distinct phases. The first being vascular rupture. So this is when you have a weakened blood vessel within the brain parenchyma, being exposed to very high levels of blood pressure, causing it to rupture, leading to blood pooling within the brain parenchyma. And we call this process hematoma formation. Now, over the first 1 to 6 hours, this hematoma will continue to expand until forces such as the brain or the pressure from the brain itself will tamponade the flow of or the formation of new hematoma. And the process of coagulation has started, leading to a hematoma that is effectively preventing additional blood from entering into that space. However, after the hematoma has expanded, that doesn't mean that the process of ICH has stopped. You're also going to develop secondary neuronal injury, particularly vasogenic edema. And that is typically worst in the 3rd to 5th day after the onset of ICH rupture. So how often does an ICH hematoma expand? So in almost 30 to 40% of patients, they will show at least a 1/3 growth in the volume of their hemorrhage from their baseline CT scan if you take the CT scan within 3 hours. And this is one of the reasons why the earlier that you're able to bring the patient into the ER after developing signs and symptoms of stroke, even if this is hemorrhagic stroke, and the earlier you intervene, the greater your chance of preventing hematoma expansion. So the golden period is no longer reserved only for ischemic stroke, but even intracerebral hemorrhage patients stand to benefit from earlier interventions in preventing the growth of these hematomas. So let's review the natural history of intracerebral hemorrhage. So we have the acute hemorrhage itself. If you notice in this particular diagram, the first half, the upper half, will show the effects of the injury, and the lower half will show the effect of early treatment on this. So in acute hemorrhage, you get mechanical edema, mechanical effect of the hematoma and edema. So the blood itself is causing pressure or compressing parts of the brain, resulting in increased ICP and direct compressive effect. After the hematoma has expanded, you start to see the evidence of secondary injury. So you get osmotic effect of the clot, increased inflammation. So thrombin, which is the product of coagulation, actually is a very pro-inflammatory a molecule, and that causes a lot of downstream edema later on and a lot of neuronal dysfunction. Then you have the toxic effects of iron from the lysis of red blood cells. So you get ferrin deposition within this area. And you have disruption of the blood-brain barrier, leading to more edema. So if you're able to evacuate this hematoma early, it is presumed that you're able to reduce the risk of secondary injuries. So after the secondary injury started to occur, you get an increasing perihematomal edema. And this occurs in almost all patients with intracerebral hemorrhage. So the earlier and the more effective your interventions are, the lesser the effect of the perihematoma will be. But if you don't intervene early, the effect will be more severe. And lastly, you get a scar, which we call a red cell lysis or erythrophagocytosis, and that leads this area, which is very prominent on MRI, showing iron deposition within this region. So the iron stays within the area of the scar from intracerebral hemorrhage. For the second component is that you may also have bleeding into the ventricles themselves. So primary intraventricular hemorrhage is actually quite rare. It's only around 1 to 3% of all cases of spontaneous intracerebral hemorrhage. And in many cases, they present with headache and aren't actually fully worked up. So this may be underdiagnosed. Secondary intraventricular hemorrhage is when an ICH in the brain parenchyma has enough force that it breaks through into the ventricles. So what happens in these patients? So with the presence of blood within the ventricles, you have a risk for developing what we call obstructive hydrocephalus. And obstructive hydrocephalus is when you have a disruption in the flow of CSF, causing more and more CSF to pool within the brain. And Sir Mac already discussed the Monroe-Kelly doctrine earlier. And if you have an impaired absorption of CSF, you start to have increased pressure from all sides, from the presence of the blood, from the edema, and then from increased CSF volume. So the adequate treatment for this is really to do an external ventricular drainage to remove the hematoma and monitor pressure. And later on, there will again be red cell lysis. However, because blood within the ventricles typically leaves no long-lasting markers of intraventricular hemorrhage, aside from mild to moderate hydrocephalus afterwards. So now we shall deal with the early post-stroke complications that are related to intracerebral hemorrhage, its management, and the concept of neuroprotection, which has already been lightly touched on earlier. So in the natural history of ICH, we can identify certain points where we are able to intervene. So in preventing hematoma expansion, we can consider hemostatic therapy, like using agents like tranexamic acid, reversal of any coagulopathies, and blood pressure lowering. So that's very useful in preventing the growth of a hematoma. Once the hematoma is formed and you have the direct compressive effects or the direct mechanical effect of the hematoma, any evacuation or surgical interventions like decompressive hemicraniectomy or an external ventricular drain would be really good at reducing the intracranial pressure and preventing herniation. Whereas for the secondary neuronal injury, which occurs secondary to excitotoxicity and the development of perihematomal edema, we really have to focus on the concepts of neuroprotection and osmotic therapy or hyperosmolar treatment. So let's begin with BP management. I will summarize our guidelines here so that we're able to be at the same baseline level of knowledge. So the current accepted guidelines are only based on two very large trials, one done in Australia, another done in China. And unfortunately, these trials have a lot of caveats. But based on what we are able to identify from the information from these two trials, we can at least safely say that if your patient has a blood pressure between 150 and 220 at the start of intracerebral hemorrhage, it is safe to target a BP of 140 and maintain a range of 130 to 150. So we have to be very strict in reaching this target because we know that this is safe and we know that this reduces the risk for hematoma expansion. However, if your baseline systolic blood pressure is above 220, it's reasonable just to decrease this by 60 for the first 24 hours before lowering the target further. And this is because every person has an individualized reaction to blood pressure. So some people with chronic hypertension, they're going to require a lot more pressure to get adequate perfusion or blood flow into the brain. And if they're chronically hypertensive and you suddenly bring the BP down, you make the patient at high risk for developing ischemia, which is an effect that we do not want for patients with ICH. Okay, so with very large or severe ICH patients, it is really good to at least try to do surgical decompression or evacuation so that you're able to better manage the risk of developing increased ICP or herniation syndromes. So for the reversal of coagulopathy, this is where our history taking comes into play. We have to make sure that our patients' medications are well understood. So we need to know if they are taking warfarin or any non-vitamin K oral antagonists like the Bigatran, apixaban, edoxaban, or rivaroxaban. Okay. The reason why is because these agents, if they are present in a patient with ICH, you need to reverse the coagulopathy as soon as possible. So this is based on the latest AHA 2022 guidelines for ICH. And unfortunately, for vitamin K antagonists or warfarin, the gold standard is really to give 4-factor PCC, which is not available in the Philippines. So in our region, it's reasonable to give fresh frozen plasma as an antidote to warfarin-associated ICH. The downside is that fresh frozen plasma takes 2 to 4 hours to properly thaw. So as a nurse or as any healthcare practitioner, and you recognize that the patient has been taking warfarin and they develop ICH, if you need to have a presence of mind to be able to thaw or start the process of thawing FFP as soon as possible so that you're able to administer it to the patient at the soonest possible time. Now, we know from our textbooks that vitamin K is the antidote to warfarin. However, what we fail to sometimes recognize is that vitamin K antagonists like warfarin work by preventing vitamin K epoxidase in the liver. So what happens then is that it prevents the liver from producing plasma proteins that are part of your coagulation cascade, particularly factors 2, 7, 9, and 10. So if your patients are given vitamin K, it doesn't mean that your liver will be able to correct all of these factors immediately afterwards. It takes around 12 to 24 hours before the full correction occurs. That's why we need to give fresh frozen plasma still for these patients in order to reverse the coagulopathy early. And then later on, vitamin K will reverse the effect of warfarin. For the Bigatran, we actually do have an antidote available here already, and that's idarucizumab. It's a very good molecule. In fact, if you just give 5 milligrams of this agent, after 30 minutes, you can already perform operations on a patient with an ICH associated with the Bigatran. So otherwise, if your patient only took your DOAC in 2 hours ago or less, you can consider giving the patient activated charcoal and pumping their stomach so that you reduce the effect of the anticoagulants here. Unfortunately, for factor 10A inhibitors, your apixaban and rivaroxaban, we don't have the antidote andexanet alpha here in the Philippines yet. All right, so Sir Mac already discussed this earlier. So one of the major ways for reducing the complications of ICH is really to reduce the complications from intracranial hypertension. And this intracranial hypertension occurs from the direct mechanical effect of the hematoma, the presence of the blood itself, vasogenic edema, and of course, the development of hydrocephalus. So all of these things have to be addressed properly. So again, we have to elevate the patient's head at least 30 degrees to improve venous outflow. Then we can consider doing interventions like therapeutic hyperventilation. So therapeutic hyperventilation has the effect of reducing ICP by reducing blood flow to the brain. And it does this because when you breathe, when you hyperventilate, you remove a lot of CO2 from your blood, so that you become hypocarbic, and the loss of PCO2 leads to a compensatory vasoconstriction. And with vasoconstriction, you have less blood flow to the brain, leading to less swelling, less edema, and less presence of blood. So this is very useful early on. However, hyperventilation is purely a temporizing measure. So its effect occurs within 10 to 15 seconds. However, its effect is transient, and it steadily becomes weaker over time. And typically after an hour has passed, the brain has become used to the current milieu of hypocarbia, and so it becomes ineffective. So one thing we have to keep in mind when we try to do this kind of intervention is that we have to understand that this can worsen ischemia. So if your patient has ischemic stroke or has intracranial atherosclerosis, or is very elderly, for example, and you suspect that they have high risk for that, um, doing therapeutic hyperventilation may cause vasoconstriction, and you may actually cause more strokes for that patient. So we have to be very careful in who we administer this treatment to. So in many cases, this is only done in very emergent patients who are acutely herniating. You can do therapeutic hyperventilation on the way to a stat OR, as a temporizing measure to save the patient's life. So this is one of the times where this can be considered. Next is our very commonly used hyperosmolar therapy. So hyperosmolar therapy is the principal medical strategy in the treatment of cerebral edema as of right now. And currently, we have two agents that are available to us. We have mannitol and hypertonic saline. Whereas in most advanced centers, we actually have a slight preference for hypertonic saline. You cannot beat the cost effectiveness of mannitol. So it's much cheaper and much easier to use mannitol if you use it correctly. So when you do have a hyperosmolar therapy as a goal, you should target an osmolality of around 320 to 340. You can use a laboratory measurement for this, or you can calculate using your BU and RBS and serum sodium. If you're using hypertonic saline, you target a sodium of 145 to 155. Above 160, there's no benefit and mostly just harm. So we try to keep it within this range. For mannitol, our target osmolar gap is less than 20 milliosmoles per liter. Again, you calculate that by subtracting your measured serum osmolality versus your calculated serum osmolality. So your mannitol is an osmotic diuretic. And what it does is that as it passes through the bloodstream, it drains excess fluid within the brain and into the blood vessels, and then allows it to be excreted within the kidney. Your administration of mannitol requires typically an inline filter because it can precipitate crystal formation, or you can give this via bolus. And actually, it's better to give mannitol via a bolus, because the more drastically you change the osmotic pressures or the osmotic milieu, the greater its osmotic effect will be. So this can be given via peripheral access, and its duration of effect is around 90 minutes to 6 hours. So keep in mind that mannitol is only effective for as long as your patient can urinate. So if your patient has no urine output or has oliguria, mannitol might be very dangerous, as it will just accumulate within the bloodstream and become less and less effective over time. So for hypertonic saline, typically abroad, they use boluses of very high concentrations of 23.4% hypertonic saline. But here in the Philippines, we use around 2 to 3% NaCl infusions. And the 23.4% bolus is really only indicated for acute brain codes or for patients who are acutely herniating, whereas continuous infusion can be used for longer term control of ICP. And ideally, when you do this, you monitor your serum sodium every 4 to 6 hours, and you try as much as possible to avoid prolonged hypernatremia, because this can cause very bad kidney injury, can cause hyperchloremic metabolic acidosis, and many other complications if your serum sodium is very elevated for too long. So the adverse effects of hypersmolar therapy have to be understood so that we can use these effectively. So in patients who are dehydrated, for example, we do not want to give mannitol, because mannitol as an osmotic diuretic can cause further dehydration or loss of intravascular volume. So ideally for patients who are dehydrated or if they're hypotensive, you give hypertonic saline in order for you to effectively improve your intravascular volume. However, the opposite can be true. If your patient is in congestive heart failure or they're already very congested, have a lot of edema, hypertonic saline might not be as ideal as mannitol would be. So other complications for mannitol include acute kidney injury. It's just very famous for that. It can cause rebound ICP elevation, especially if you abruptly discontinue this. It can also cause electrolyte imbalances, particularly hyponatremia and hypokalemia. So loss of sodium and potassium in your urine because of mannitol. For hypertonic saline, your complications include pulmonary edema if you give a large volume immediately. It can also cause acute kidney injury and coagulopathy to a lesser degree. Of course, hypernatremia is one of its major adverse effects. So you really want to do regular testing in order for you to prevent any of the major, prevent overshooting your sodium levels. You can also develop hyperchloremic metabolic acidosis, thrombophlebitis, especially if you're giving this in a peripheral line. Ideally, if you have a 3% or above sodium solution, it has to be given through a central line. And you can also cause osmotic demyelination syndromes if you use hypertonic saline in a patient who is hyponatremic. So this is your central pontine myelinolysis. So you have to be very careful for all of these things. So Sir Mac has already discussed the second part of this, which is neuroprotection. So in our schema for managing our patients with intracerebral hemorrhage, neuroprotection is actually a very important part of this. And we first have to be clear on our definition of what neuroprotection is. So neuroprotection isn't just a medication or a single agent that we give in order for us to be able to improve our patient's recovery. Rather, neuroprotection is a philosophy. It's a strategy where we antagonize, interrupt, or slow down the consequences of injurious biochemical damage that leads to neuronal dysfunction or death. So this does not necessarily require a pharmacological agent be given. Rather, this leans very heavily on doing your acute specific treatment as fast as possible in the correct manner and optimizing the physiological status of your patient. So these are the components of neuroprotection that we advocate for. So early specific treatment in ischemic stroke, that's reperfusion treatment, whether that's thrombolysis or thrombectomy. For hemorrhagic stroke is early surgical intervention if indicated. For subarachnoid hemorrhage, it's early securing of the aneurysm. So these are all the core components for neuroprotection. Physiological optimization will include the core tenets of BP management, blood sugar control, control of temperature and prevention of infection, dysphagia management, and comprehensive rehabilitation. So all of these things will protect your brain and lead you towards an optimal recovery. Lastly, you do have pharmacological agents that you often see many physicians prescribe. Many of these have studies that are very complicated to go through, and we don't have really much time to discuss all of this in detail. But one thing that I want all healthcare practitioners to know is that these pharmacological agents are adjuncts to standard care. They do not replace good rehab. They do not replace good nursing care. Because honestly, good rehab, good nursing care, physiological optimization, and good specific treatment as given early That's 99% already of the improvement in stroke outcomes we have developed. So in glucose management, so you always see that physicians with patients with ischemic or hemorrhagic stroke, we want fairly frequent glucose evaluation, especially in the first 24 to 48 hours, because we have a very tight area of control. So ordinarily, if you target a normal CBG of like 60 to 100, you're at increased risk for developing neuroglycopenia or decreased blood sugar within the brain and leading to a metabolic crisis. Why? Because in acute brain injury, whether that's because of stroke or traumatic brain injury, there's increased in metabolic demand for the brain to function normally and for the brain to start the process of recovery. And if you deprive the brain of the much needed glucose, you will actually lead to worse outcomes. On the other hand, excessively high blood sugar will increase your oxidative stress, cause inflammation, cause endothelial dysfunction, and cell death. So thankfully, we've had many large trials, including the NICE Sugar trial and the SHINE network trial for stroke patients. And we've identified the sweet spot of 140 to 180 being your optimal target for patients. So if your patient is hyperglycemic, you target a CBG of 140 to 180. But if your patient has normal glycemia, 100 to 180 is our target. Okay, so that's the long and short of glucose management. What about fever and infection? So we first have to recognize that fever and hyperthermia can both occur in patients with stroke, whether it's because of infection or non-infectious processes. Fever is secondary to a process that changes the set point of your thalamus. Parang binabago nila yung thermostat ng body mo. That's why you develop a fever response. Whereas hyperthermia is a direct, it bypasses the hypothalamus and causes direct increase in temperature through your autonomic nervous system usually. So whenever you develop fever, it's very important to first and foremost rule out infection, because infection is one of the major causes of poor outcomes in patients with stroke. And of course, if you can't find any sign of infection, you have to make sure that you're not missing out on any DVT or thrombophlebitis, that you're not missing out on atelectasis or dehydration or even myocardial infarction. And not identifying these possible conditions can be very deleterious to your patient long term. So for fever and infection in stroke patients, our target is to reach temperature less than 37.8 degrees. Currently, we don't have any evidence for therapeutic hypothermia in patients with intracerebral hemorrhage. In fact, its use is very narrow. So what we are limited to doing is using paracetamol to prevent fever. You don't just treat the fever, you also search for the cause and address its cause. You can consider giving non-steroidal anti-inflammatory drugs like celecoxib or mefenamic acid only if your patient is not at the risk for acute kidney injury or myocardial infarction. You can also give opioids like tramadol and fentanyl, especially if your patient has severe pain. Severe pain actually triggers your autonomic nervous system and can cause fever as well. And if you have patients who are shivering or have problems like that, opioids can also be very useful in controlling shivering events and chills. So for oxygen support, again, if your patient has any signs of desaturation, so if your O2 sat is less than 94, that's when you start giving supplemental O2. You do not give supplemental O2 in non-hypoxemic patients. It's already been shown to cause more harm than good if you give O2 blanket for all stroke patients again. In patients with decreased levels of consciousness, typically meaning a GCS score of 8 or less, or patients with severe bulbar dysfunction, even if they are awake, but if the bulbar dysfunction is severe enough that it can compromise their airway, you might want to consider airway and ventilator support. So that's it for the early post-stroke complications. Now we'll go into the larger meat of the topic, which are your late post-stroke complications. And many of these, I'm sure most of you will know a lot of them, but there have been many advances in the way we screen, diagnose, and manage a lot of these complications. So I invite you again to look at the main processes of stroke care. And as you see, the upper part here is essentially the phase of management, and the lower parts are the complications through time that you would see. So as the stroke has occurred, your first goal is really to do early management of your ICH. So that prevents hematoma expansion, surgical treatment, and control of intracranial hypertension. Soon after, as edema develops, it would be good for you to initiate your treatment for this, which is mostly hypersmolar therapy or surgical intervention as needed. Now, once you've reached past the very acute point, it is our goal now to really control for any infections, cardiac complications, stroke recurrence, seizure development, deep venous thrombosis or pulmonary embolism, cognitive impairment, depression, fatigue, sarcopenia, falls, fractures, and pain. So you can see this, you have an early subacute and a late subacute set of complications that we have to watch out for. And we'll be discussing all of these in greater detail. So again, these are the things we'll consider. We'll also discuss bowel and bladder dysfunction, and we'll expand the cognitive problems to mental health problems and all in all. So post-stroke infections are very common. So they have an incidence of around 30% in when you look at longitudinal descriptive studies. And post-stroke infection is associated with about 20% of deaths and related to considerable morbidity and mortality in stroke. Considerable morbidity in stroke survivors. So the more severe any infection you develop is, the longer that you'll probably be on a ventilator, the longer that you'll require a catheter of some sort, the longer that you'll require critical care, and the longer your hospital stay would be. And of course, that will lead to worse outcomes overall. Infection also interferes with a lot of the repair and recovery processes that occur within the brain early on, as the brain is recovering from the stroke. So why does this occur? So stroke has four major side effects that can lead to an increased risk for infection. The first being immobility and symptoms directly caused by stroke. So if you're immobile and you have bulbar dysfunction, so you're likely to have aspiration, these things can cause all of these infections directly. You also have stroke-related treatments, such as the use of urinary catheters that are unnecessary, or intravenous lines that are not aseptically placed, that can lead to thrombophlebitis or catheter-related UTI. Next, you also have brain-induced immunodepression, meaning that the processes of stroke and inflammation within the brain leads to a hypersympathetic effect. It's like you're developing a lot of excess glucocorticoids, and that can cause immunosuppression. And lastly, we have to consider the patient characteristics related with stroke. So if your patient is diabetic, or if they have HIV, if they have cancer, COPD, or anything with chronic inflammation, even obesity, they're at greater risk for developing infection. So what is the impact of infection and stroke outcome? So fever, just the presence of it can lead to a negative outcome in terms of worse morbidity or increased risk for mortality in 38 to 61% of patients, which is why we control fever as much as we can. Infection, which again has a very varied incidence rate depending on the methodology or the definitions that we use, can occur in 20 to 61% of patients. It's the most common complication after stroke, and it occurs more often if your stroke is more severe. And lastly, you have pneumonia. So depending on your study, the rates of pneumonia can be 5 to even up to 15%. And pneumonia is the #1 cause of death in post-stroke patients, with a significant odds ratio of up to 14 times increased risk compared to a patient with ICH who does not have pneumonia. So pneumonia will often lead to sepsis, and if it's not recognized or treated immediately, that is what usually triggers the cascade towards death for our post-hemorrhagic stroke patients. So how does stroke-associated pneumonia occur? So again, with your stroke affecting the brain, you have an increased activity of your sympathetic nervous system, leading to increased secretion of catecholamines, which actually increases the production of glucocorticoids. It increases pro-inflammatory cytokines that actually leads to stroke-induced immunosuppression syndrome. This can also lead to a change in a lot of the hormones within our body, leading to decreased lymphocyte counts. So if you notice the WBCs of patients who are post-stroke, they typically have neutrophilia, decreased lymphocyte counts, and that leads to generally poor immune function. And of course, the presence of any edema, tissue inflammation, increased neutrophils and alveolar macrophages can also precipitate lung injury developing. So even if you do take very good care of the patient's airway, the patient did not vomit, they are structurally still at increased risk for developing pneumonia just because of this excess lung injury. What about UTI? So depending on your stroke severity, most patients were typically placed on indwelling Foley catheters before. And that's so that it makes it easier to do nursing care and procedures. However, it's been recognized that if it's not necessary, you should avoid using indwelling Foley catheters because it increases your risk for urinary tract infection. So other things that are related to stroke that may cause more UTIs, increased post-void residual volume, leading to more stasis, especially in women, which will lead to increased risk for UTI. Of course, immune suppression is still in play here. So all of these things can increase your risk for UTI post-stroke. So how do we manage post-stroke infection? So number one is really to reduce the use of permanent urinary catheters to when it's absolutely necessary. Number two is to do early mobilization of patients without severe motor deficits. The value of this is twofold. Number one, movement prevents sarcopenia from developing. And if you do develop sarcopenia, it further worsens the inflammatory cycle that's occurring in your patient. So if you're doing early mobilization, you prevent more inflammation and you decrease the risk for infection. Second, early mobilization allows you to prevent bed sores from forming. It allows you to have proper removal of any excess mucus or secretions from your pulmonary tract, especially from your lungs. So if you have a lot of phlegm, for example, early mobilization can help reduce the buildup of excess phlegm. Of course, we need to do dysphagia screening and assessment, and this should be repeatedly done and not just done once. So you continue to observe the patient. If they have any signs of difficulty, that could mean that the patient has a progression of their stroke, or edema has formed, leading to new stroke deficits appearing, and a lot of other things that you have to consider. So, and patients who cannot take food and fluids orally should receive NGT or PEG feedings to maintain hydration and nutrition while undergoing efforts to restore swallowing. As much as possible, we do not want to give TPN in patients with stroke because TPN actually also causes a increased inflammation and immunosuppression, leading to increased risk of infection, especially blood bacteremia and thrombophlebitis. So always keep a high index of suspicion at all times for infection. Now let's address the elephant in the room. What about the use of prophylactic antibiotics? So prophylactic antibiotics have been shown to reduce post-stroke infections. And this is based on a large meta-analysis of 7 different trials that compared using prophylactic antibiotics and stroke outcomes. However, even though it reduced post-stroke infections, it did not affect outcomes in any significant way. Furthermore, the effect of prophylactic antibiotics seemed to improve or prevent the formation of UTI. However, it had little to no effect in reducing stroke-associated pneumonia. So we don't actually have a role for prophylactic antibiotics. But if you do have a high clinical index of suspicion, for example, if your patient has vomited or on X-ray, there are signs of infiltrates, or if you have clinical features on auscultation or chest examination that are suggestive of pneumonia, you can give antibiotics in those cases. You just don't give it prophylactically without any good reason. Next is our dysphagia screening. And the one that is recommended by the Stroke Society of the Philippines is the Gogging Swallowing Screen, which has two parts. The first is your indirect swallowing test, which is essentially you're observing if the patient is capable of maintaining their wakefulness, able to cough or clear their throat, and able to swallow their saliva. The second part of this test involves direct swallowing. So you use three different agents, a semi-solid, a liquid, and then a solid. And you check the effectiveness of their deglutition, the patient's cough, before, during, or after swallowing. So you check even until 3 minutes after if you see if the patient has any involuntary cough, if the patient has drooling, or if there's a change in voice. And in general, we get these very large scores. So you get a score of 0 to 9 for severe dysphagia, 10 to 14 for moderate, and 15 and above for slight to no dysphagia. So the important thing to just keep in mind here is that a GUS score of 0 to 14 indicates a moderate to high aspiration risk. And this is 100% sensitive, but only around 69% specific. So if you do have a GUS score of 0 to 14, you have to assume that the patient has very high risk for aspiration. And that might even necessitate the use of an NGT, or in very severe cases, the protecting the airway with endotracheal intubation. Oral care is also another very important component here, and I don't Sir Mac didn't mention this earlier, but he's one of the foremost advocates I've seen for improving oral care in all post-stroke patients. He's very strict in making sure that everyone has this done properly, and he continually trains nurses to do this very well. So upon admission, all the healthcare team should assess the patient's oral and dental capacity, meaning if they look for dental caries or any signs of dental disease. You should check if they have any appliances, such as any postizo, and you should apply an appropriate oral care protocol for all of these patients. So typically, it is the nurse's responsibility to determine the appropriate frequency of oral care, but ideally this should be done after meals and before bedtime, or 3 times to 4 times a day if your patient is intubated. And you also choose the type of oral care product to be used. All right, so next we go into cardiac complications post-stroke. I will not go into this very deeply, but there are 3 things I just want the audience here to know. The first is that the brain and the heart are intimately connected in what we call the heart-brain axis, or as we neurologists prefer to call the brain-heart axis. So in this axis, there's an intimate connection between the two, and developing any injury to the brain can actually increase your risk for developing any cardiac or coronary problems as well. The main cause of this is the sympathetic hyperactivity of secondary to catecholamine release and in autonomic dysregulation. So typically, the first signs that you would see of any stroke-induced heart injury include electrical abnormality. So these patients might develop arrhythmia, even atrial fibrillation. And then later on, they might have non-infarction acute coronary syndromes, meaning that there's direct injury of the cardiac myocyte secondary to the stroke. Even though the blood vessels of the heart, the coronary vessels, are not badly affected. And that can lead to increased troponin levels, which is why sometimes you will see patients post-stroke, they might have STEMI-like changes on their ECG, they might have very large T or U waves, and you might have very elevated troponin levels. And it's because the two are very closely related. And it's really up to the medical team to address these issues. So next is we have post-stroke seizure. Um, Post-stroke seizure is actually a common and very important complication of a stroke. And unfortunately, this occurs more commonly in hemorrhagic stroke than compared with ischemic stroke. And the incidence rate is approximately around 7%, with a very high recurrence rate. So if you've had a post-stroke seizure, 30% the chance of repeating a seizure in 1 year and 50% in 2 years. So stroke actually becomes one of the most common causes of epilepsy in patients above the age of 60. So if you're above 60 and these patients have epilepsy, almost half of them are because of some kind of post-stroke change. So the pathophysiology for this is really the damage that the stroke does to the cortex and subcortex, and the resultant inflammation and neuronal excitotoxicity. So excessive neuronal excitotoxicity can lead to an early seizure. So this typically you'll see within 12 to 72 hours after the stroke onset. And in the case of subarachnoid hemorrhage, it can even occur at onset of your aneurysmal rupture. So that early seizure is really just a very early exaggerated excitotoxicity. However, as your stroke recovers, if it affects the brain's cortex and the subcortex to a large degree, the process of scar formation or gliosis can actually lead to an epileptic focus forming in the recovering part of that brain. And that can lead to a late seizure. This typically occurs between 3 and 12 months after the stroke has occurred. So when we try to address these patients, we try to predict if they'll develop post-stroke seizure, what we can do to prevent this from developing, what drugs we can use, and how we advise our patient's family. So we do not recommend EEG for all patients with a frank seizure. It should only be considered in patients with a possibility for subclinical seizures, meaning their CT scans are good, but these patients are confused. They have waxing, waning sensorium. You don't have any signs of sepsis or anything that could be affecting the patient's sensorium. For prevention and prophylaxis, currently, no treatment with any anti-seizure medication has been shown to reduce post-stroke epilepsy. So we don't give this to prevent seizures. An exception would be in subarachnoid hemorrhage, where much of the time you would see us giving these medications prophylactically, because if a seizure occurs in a patient with subarachnoid hemorrhage, that can trigger rebleeding. So we typically try to avoid that. Next, for your choice of anti-seizure medication, we have to individualize the treatment to our patient's needs, choosing the most effective based on the seizure type and the most tolerable according to what the patient's characteristics. Lastly, we explain to patients that post-stroke seizures are a form of epilepsy and that treatment may last for a long time. Many times, the patients with post-stroke seizures come back to the ER because they stop taking medications for a week or so, or they develop infection, lowering their seizure threshold. So it's very important for the family to understand that this is a long-term problem, and that if you are able to maintain good seizure control, your patient will more likely have a healthier, happier life. Next, we'll talk about post-stroke bowel and bladder dysfunction, beginning with urinary incontinence. So as you can see on the diagram on the right, your urination actually has two large centers of control within the brain. The one of them being in the anterior cingulate cortex in the paracentral gyrus, and the other being in the pons. And if you do have a stroke affecting either of these two regions, it's very possible that you'll develop urinary incontinence. And in fact, post-stroke urinary incontinence has a very high incidence rate of up to 21 to 79%. Thankfully, lower centers of control or other centers, if for example, if the pons is affected but the cortex is fine, so other centers might actually take charge, and you can resolve this problem within 4 to 8 weeks of stroke onset. So in only around 14 to 19% will you have long-term early incontinence after 6 months. Typically, you see this in patients with very large, very severe strokes who are also likely to be bed dependent or bed borne. So how can nurses and the healthcare team manage urinary incontinence? First is if for patients who are very healthy or more functional, you can encourage Kegel or pelvic floor exercises. So you tell them to stop urination midstream. You instruct the patient to tighten their anus or urethra, and you do this at least 3 times a day with 10 repetitions each time. You can also do bladder training, timed or scheduled voiding, and early access to using commodes and toilets so that the patient is encouraged to master their control of their bowel and bladder again. And of course, you have to strictly monitor your input and output because you need to make sure that the patient is not having any excessive bladder buildup, for example, or dehydration. For urinary retention, which is a separate problem, you can do voiding trials. So you encourage the patient to try double voiding. You use bladder ultrasound to measure post-void residuals to see if it's effective at all. Then you have a prompted voiding toilet program. This is another way of using a private commode or toilet and telling the patient that they have to use this at a fixed schedule. And lastly, you can do intermittent catheterization every 3 to 6 hours to prevent overdistension of your bladder. You can also consider medications like botanical for neurogenic bladder. So for bowel dysfunction, this occurs in up to 66% of post-stroke patients, especially the problem of constipation. Fecal incontinence, however, is also a fairly common problem seen in 7 to 50% of post-stroke patients. But most of these patients will have this problem resolved in less than 10 days. And you only see this in patients with very large anterior circulation strokes, meaning that they are likely in a persistent vegetative state or a comatose state. So how can we improve our patients' quality of life if they have bowel dysfunction? First, we have environmental and lifestyle modifications. We need timely and regular bowel habits. You address any functional limitations that prevent the use of a toilet or commode. So for example, if your patient has difficulty walking, you need to provide the patient with a safe environment to use the toilet or assistance to help them walk there. You can do diet modification by increasing fiber in your diet. Sorry. And avoiding food or drinks that cause constipation. Of course, you need to do very good perennial skincare as well. You should consider the use of applying skin barriers or creams to prevent the formation of rashes and eventually ulcers. And of course, medications as needed for the specific problem. So you can give laxatives or prokinetic agents if you have constipation, and constipating agents if you have fecal incontinence. All right, so for our next major set of issues, we have the mental health problems after a stroke. So this is a very large spectrum of conditions that affect the psychosocial, emotional well-being of a patient. And the most common ones are the 6 I've listed here: apathy, anxiety, depression, and of course, post-stroke emotionalism. This is a very under-recognized but a very severe problem in some patients with stroke. Chronic fatigue, another major problem, and sleep problems. So all of these issues together will affect long-term stroke recovery. If you're depressed, you're not going to have very good engagement with your rehab. You're not going to take your meds regularly. If you're fatigued, you're not going to you're anxious, you're not going to comply with a lot of your medical team's advice. So all of these issues lead to suboptimal outcomes, poor well-being, and poor quality of life. And we have to recognize that even if the patient has recovered very well after a stroke, like they're able to ambulate independently, they can do most ADLs, these problems may still be present with them. Okay, so even if you have a young patient who recovered almost fully after a stroke, many times if you really interview them or get to know them, you'll see that they might have anxiety, fatigue, or depression. And it's very disheartening that we don't give enough attention to these problems, especially in the age of the Mental Health Act. We have to be more aware as healthcare practitioners for identifying all of these things. So let's first go with post-stroke emotionalism. Above is an illustration of a woman who goes through a whole spectrum of emotions very rapidly. So this is post-stroke emotionalism is what we used to call pseudobulbar palsy, emotional incontinence, or emotional lability. So this is a very rapid shifting of emotional states. And this can affect up to 25% of stroke patients during the first 6 months after a stroke. And you might not recognize these very immediately, especially if you're in the ICU, since your patients are typically intubated. But in patients who have mild disease or moderate disease and are not in the ICU, these are patients who will have sudden onsets of laughter, tearfulness, and oftentimes they just suddenly change their mood while their family is visiting or something happens. Thankfully, because in our culture, the Filipino culture is very much more emotionally in tune, and there's much more family and emotional support. We don't see this as much as a problem as compared to other countries. How do we treat this? We can give the antidepressants for some of these patients, and in others we give dextromethorphan. So to differentiate post-stroke emotionalism versus depression, the gamut of post-stroke emotionalism or pseudobulbar affect is much larger. So sometimes you're crying, laughing both, and then suddenly you just stop. You're completely apathetic. And depression, typically this can be very brief. Sometimes just last seconds, minutes, and it might be very hard to catch if you're not observing the patient closely. And pseudobulbar affect is often uncontrollable, even at the patient's best attempts to control. And of course, this can be very exaggerated. The patient might be crying, but they're happy, or laughing, but they're actually very sad. And of course, if you have outbursts, they don't typically have any link to any underlying thoughts. Unlike in depression, outbursts typically are exacerbated by feelings of worthlessness, hopelessness, eventually leading to suicidal ideation. So now we go to post-stroke depression. So this can be seen in up to 33% of stroke survivors, and 40% of this 33% remain symptomatic even a year after that they've had their stroke. And the major contributor is physical disability, but this can also happen in patients with mild strokes. One of our papers that we did in the Philippine General Hospital in 2020, we identified that post-stroke depression in even young patients who have very good recovery is present in around 30% of this population. And 70% of the stroke in the young patients that we've interviewed actually don't go back to their regular job or don't go back to their regular functionality, even if they are capable of returning to their previous work. And it is important for us to really understand the societal components that are at play here, the cultural belief of the patient, and the length of time and support systems that we have for stroke recovery to occur. So post-stroke depression always reduces the quality of life after stroke. It increases your mortality rates and increases the rates of healthcare use after stroke has occurred. So oftentimes, if you have post-stroke depression, it's a really poor marker for outcome. And predictors of post-stroke depression includes physical disability as the number one again, stroke severity, the presence of depression before stroke onset, any significant cognitive or language impairment, a lack of a family or social support system after the stroke, your loss of productivity, and anxiety. So these are the symptoms that we check for in patients with stroke. The core features, of course, have to be a depressed mood, meaning that they feel depressed most of the time, and anhedonia, or loss of interest in doing anything, or loss of pleasure in all activities or most activities. The other symptoms that you look for are weight loss or gain, insomnia, psychomotor agitation or retardation, fatigue, feelings of worthlessness or excessive inappropriate guilt, decreased concentration, and lastly, thoughts of death or and suicidality. So the presence of any of these is a red flag for us that we need to intervene and to manage these patients well. So how do we treat our patients with post-stroke depression? The early initiation of antidepressants has been advocated for by many neurologists and psychiatrists alike. And more often than not, this can reduce the risk or severity for post-stroke depression. However, you have to monitor this closely for their effectiveness. So typically, the medications we give are SSRIs like fluoxetine and escitalopram. Psychotherapy, particularly cognitive behavioral therapy or motivational interviewing or psychosocial interventions are very useful in improving our patients' depression. Sometimes they might have other factors that they have to address, not just the stroke itself. Finding a stroke support group would also be very important. So any local group, whether it's family members or neighbors or the community, if they do have other stroke patients, knowing that other people are going through what they are can be a huge relief for them in some way, and that they can encourage one another to try and continue their rehabilitation and stroke treatment. Exercise, of course, is also very important, especially if your patient is only mildly impaired or not impaired at all. So once cleared by the medical team, the patient should undergo regular low to moderate intensity exercise appropriate to their level of functionality. So it has already been shown that dance, yoga, and other low impact activities but have been shown to improve mood significantly after. And there are novel treatments like neuromodulation or transcranial magnetic stimulation that are currently being studied in many places. In fact, deep transcranial magnetic stimulation is already class A level of evidence for reducing depression, and especially in patients with brain injury of any form. So post-stroke fatigue is the sensation of exhaustion during or after usual activities, or a feeling of just generally inadequate energy to begin any activity. So parang demotivated yung patients talaga. And this is associated with high morbidity and mortality rates as a secondary effect because they don't expend as much energy. They are more likely to have a sedentary lifestyle or be completely bedbound, which will increase their complications from being bedbound, increase inflammation, and that leads to these complications. And this can be experienced at any point in the recovery period. And that doesn't mean that you feel this just the first month after the stroke. You can start feeling this 2-3 months after the stroke has occurred and your ongoing rehab. So this fatigue is multidimensional. It has a motor perceptive component, meaning the feeling of strength and the feeling of your in tuneness with the environment. And you have an emotional and cognitive component here. So you can have demotivation as being one of the problems. So this can present as an inability to perform ADLs, an increased need to sleep, nap, or rest, even though the patient has more than adequate sleep and of good quality, and unpredictable tiredness. And of course, this can be objective, subjective, or both. And the way we treat this is to give cognitive behavioral therapy. So these are guided therapeutic exercises trying to replace or understand certain behaviors through a framework that is developed by the therapists doing these things. You can do mindfulness training, typically deep breathing exercises has been shown to improve post-stroke fatigue and post-stroke cognitive impairment. You can give stimulants like modafinil or antidepressants like fluoxetine and escitalopram. So these are things that you can consider for patients with fatigue. So as part of the mental health problems, although this isn't exclusively a mental health problem, is sleep problems after a stroke. And as you can see in this diagram here, stroke, when it leads to disturbed sleep, leads to significantly worse outcomes. Sleep is an essential activity of the brain. that allows for your brain to recover properly. But what many of us don't understand is that we need good quality sleep. And good quality sleep is your slow wave or stage 3 and stage 4 sleep. And if you have sleep disordered breathing like sleep apnea, if your environment is very loud or stimulating and you don't reach stage 3, stage 4 slow wave sleep, your chance of getting good neuronal recovery is much less. So disturbed sleep leads to decreased neuroprotection, decreased synaptic plasticity, and increased inflammation. And the opposite is true if you have undisturbed sleep. And that's why it's very important for us to address these problems. So what can we do? If your patient has obstructive sleep apnea, consider using a CPAP device. If your patient has restless leg or restless body disorders, you can give levodopa and dopamine antagonists. You can give gabapentin in order to correct that. If they have REM sleep behavior disorders, you can give clonazepam, melatonin, or fluoxetine. If they have insomnia, you can give antidepressants, zolpidem, or do cognitive behavioral therapy. So keep in mind that the treatments for insomnia here don't include benzodiazepines, because benzodiazepines like diazepam or midazolam, they do sedate the patient. But sleep is an active process of the brain. It has a different circuit of the brain which is active, not the usual one that you have when you're awake. And when you give a benzodiazepine to a patient, all of these circuitries are decreased. So you don't get good quality sleep if you give a patient a benzodiazepine. The same is true if you give antihistamines like diphenhydramine. Diphenhydramine is very good at inducing sleep, but the sleep quality that you'll have is very poor. And upon waking, you typically have increased risk for developing delirium or developing grogginess, long-term grogginess. So next we go to post-stroke cognitive impairment and the dementia. So in general, any cognitive problem or feature of dementia or neurocognitive disorder that manifests after a clinical stroke is categorized as vascular, even if you have a coexisting presence of Alzheimer's disease or any other neurodegenerative pathology. You can consider these a mixed type dementia or a vascular plus dementia. So what happens in a patient with post-stroke cognitive impairment? In patients with large intracerebral hemorrhages, a very large lesion that affects the cortex is likely going to lead to long-term cognitive deficits. However, our intracerebral hemorrhage is actually just a manifestation of a wide spectrum of diseases that we call small vessel disease of the brain. And the small vessel disease of the brain is usually caused by hypertension, diabetes, smoking, a sedentary lifestyle, and atrial fibrillation. And all of these things increase the risk for the blood vessels of the brain developing abnormalities, increasing the risk for ICH, subarachnoid hemorrhage, small infarcts and lacunar infarcts, and many other problems. And cumulatively, all of these problems can lead to cerebral shrinking or atrophy, can lead to the presence of white matter hyperintensities or the bright spot in MRI, cerebral microbleeds, and other mini stroke-like presentations. So small vessel disease, thromboembolism, and hypoperfusion can lead to reduced cerebral blood flow, which causes hypoxia, inflammation, and oxidative stress. And these three processes lead to diffuse damage of the brain, especially the white matter, and some neurodegeneration. And that eventually leads to cognitive decline and vascular dementia. So the way that the stroke can affect cognition can be in many patterns. So for the first one, the green one here, is the expected evolution. So over time, as we age, we expect the cognitive functions that we have to slowly deteriorate. However, in a patient with small vessel disease of the brain, you would see a more rapid but gradual decline. In some patients with a transient ischemic attack or a small stroke, you can have an an immediate effect on cognition with the recovery, but they'll never be back to the baseline level that they were before. You can have a steep decline followed by a gradual decline. So this, you see this in patients with large strokes causing aphasia or causing other cognitive problems. Or you can have a stepwise decline. So parang with every stroke event, the patient's cognition continues to worsen. So these are the symptoms that we watch out for in patients with vascular dementia. Memory loss, slowed thinking, depression and anxiety. Locomotor problems like gait disturbances, so yung parang very unsteady gait with very small steps, which we call marche petit pas, parang march of small feet. Dysarthria and autonomic dysfunction, including orthostatic hypotension. The loss of executive function, meaning that they have poorer problem solving, poorer concentration and working memory, worse judgment, and very bad reasoning. So in patients with vascular dementia, memory is not the primary problem. It's this executive function, executive dysfunction that is our main problem here. So these patients parang makulit sila. They don't understand what's going on, but they have a fairly okay memory. Like if you ask them questions, they know what's happening. It's just that it's easy to lose them. Parang mabagal talaga yung pag-iisip nila. So what can nurses and other healthcare professionals do to address these issues? First is to assess the type and degree of cognitive impairment. So there are many cognitive domains, but the ones that are very important to us are the sensory perceptual involvement, motor skills, and language skills. Of course, we have to discuss the patient's condition with the family, explain to them why they are having these problems with their cognition or language, and we have to review the current restrictions we have for them and discuss potential resumption of activities. So especially early mobilization and feeding. Next, we control vascular risk factors. Earlier, I said hypertension and diabetes are the most important risk factors for developing small vessel disease. So if you control these, you may slow down the development of vascular cognitive impairment. Of course, you have to encourage communication with the patients themselves. When we go in, we don't just ignore them and not talk to them. You talk with them, even if they don't respond. You orient them to the day. Tell them that, oh, it's Monday today, or it's Friday today. And then tell them the current events like, oh, bumagyo, may earthquake, ganun. Just so that the patient continues to be engaged, that they're continuously testing their cognition and giving them mental exercise. Next, you also reduce excessive environmental stimuli during cognitive exercises. So if you're talking to them, silence the alarms, don't make the room too bright, just the right amount of light so that they're able to focus more on you as the healthcare professional or the patient's family when they visit. And of course, we want to allow the patient ample sleep and rest between sessions of activity. So if you don't have good quality sleep, your chances of recovery will really be much poorer. Now, I'll give a special mention to post-stroke aphasia because this is one major cognitive impairment that does have a large effect on the functionality of a patient, even if they are ambulatory after the stroke. So aphasia is, simply speaking, is a disorder of language. It's not a specific problem with our maybe hearing or our capacity to produce our voice or to modulate our voice or articulate speech. But it is more the process of language in the brain itself, and that can manifest as trouble speaking clearly. Oftentimes they have agrammatic speech, or they replace words with one another or syllables with one another. They can have trouble understanding speech or written words, meaning that what they don't understand the auditory commands that we give them, but if you use gestures or if you use facial expressions or pictures, they're much better able to understand. They can also have trouble remembering words, trouble writing, and trouble remembering the names of objects. So sometimes they describe an object in a circumlatory way. Like instead of saying a pen, sabi, ito pwedeng magsulat papel, but they don't know the name of the object. So these are symptoms of aphasia. So what can we do to help patients with aphasia? We have to encourage the patients who have this problem that they should take their time, try not to be frustrated. And of course, on our side, we have to be very patient so that they don't feel like we're pressuring them or that we're frustrated with them. The patient should try to be able to admit if they're struggling, try to say what is effective in helping them communicate. And of course, we should feedback that by speaking in short, simple sentences and by removing any distractions while they are trying to talk to us. So we can be creative and use assistive devices, such as boards like this. So these are pictogram communication boards where where a patient can point to to these wants or needs so that they're able to communicate with the patient. So these have words, these have pictures, and these pictures should be very clear in what they're trying to convey. So my comment here, for example, is the temperature one. It might be very difficult to interpret. Same thing for the sit up and lie down. It might be better to have a larger, clearer illustration. So the point is you have to make a very clear and a very effective way for a communication board to really work. Next, DVT prophylaxis. This was already covered by Sir Mac earlier, but I just want to share the Canadian best practices for this, where they have 4 steps of thromboprophylaxis. So the first is question yourself at each step of the way, with the first question being, is thromboprophylaxis indicated? And if your patient has a stroke, the answer will always be yes. Okay. So the next question is anticoagulant thromboprophylaxis contraindicated? If your patient has bleeding or is at high risk for bleeding, in cases of intracerebral hemorrhage, if they do have those, then you can give your TED stockings or sequential compression devices, but you reassess the need for pharmacological thromboprophylaxis daily. So the third step is to apply the appropriate thromboprophylaxis, whether it's low molecular weight heparin or a novel oral anticoagulant. And of course, you reassess if there are any changes in the patient's status or is it a transition of care. So for patients with intracerebral hemorrhage, general wisdom is that we do not initiate any anticoagulation within the first 48 hours after a stroke. After the 48 hours, the evidence is less clear. So it's more a measure of the risk versus benefit. So if your patient doesn't have any DVT right now, is at low risk, you might want to give anticoagulation 7 to 14 days after, or even longer. But if your patient has, let's say, a thrombus in the heart and needs anticoagulation rapidly, then, or they have an active DVT with a floating thrombus, then you might want to give it earlier. So you have to individualize this to your patient's needs. And these are our treatment approaches for patients to prevent DVT in stroke patients. Next, we'll be dealing with post-stroke spasticity and pain. So stroke, one of the main features is, especially if you remember your upper motor neuron versus lower motor neuron problem, is that if you have an upper motor neuron problem like in stroke, it can lead to abnormalities in muscle tone. And the most common one is spasticity. So on the diagram on the right side, you can see that in the first few days, you might actually have a flaccid patient, even though this patient has obviously an upper motor neuron disease like in a stroke. But after the first 7 to 10 days, spasticity may slowly develop and worsen over time. And if you do not address this, contracture formation may occur. So for some, spasticity can be very mild, muscle stiffness, but for others it can be very severe, leading to very bad pain or spasms, and that it also has to be addressed. So here are some examples of post-stroke spasticity. So having a clenched fist, tensed fingers with a bent arm held against the chest. This is one of the most common features of post-stroke spasticity of the upper extremity. You may or may not have shoulder problems with this, such as your shoulder subluxation. Again, you can feel like parang loose yung shoulder, parang the shoulder joint is out of its socket. You can also have post-stroke spasticity of the lower extremity, where you have a foot that's bent at an angle or a foot drop, such as the left leg in the illustration there. You can see the foot is dropped so that you have difficulty going upstairs or walking because it's more difficult. It's more difficult to clear the ground with your foot dropping like that. So how do we manage patients with post-stroke spasticity? So if you identify someone with that, you first check if the area that has spasticity is very important to their functionality. And if it is, you should do a multidisciplinary plan to address this function. So physiotherapy and nursing, physical therapy, and all of these services have to work together in order for you to make a good plan to assess the spasticity and to prevent it from getting worse. If you then assess for triggers and aggravating factors, such as the presence of any infection or broken skin, and you also look for other problems that may complicate your rehabilitative plan. So once you've identified that you need to do rehabilitation, you start devising a physiotherapy and nursing treatment plan. So this will include soft tissue and joint range motion, splinting or optimizing position. So in some cases, you would see a foot splint to address a foot drop, or a volar thumb splint in order for you to maintain a good function of your hand so that they're able to grip well after, and that it's not bent and closed like what you saw in the drawings earlier. Then you can do things, measures to optimize positioning or seating the patient. And you can do very early standing programs in the gym as with support. So if your spasticity is still problematic, despite your optimal physiotherapy and nursing plan, you can consider giving botulinum toxin if your problem is mostly focal. But if it's a generalized problem, like the whole body has spasticity, you might want to consider giving intrathecal baclofen or oral baclofen first, so that you reduce the spasticity or the tone of your body. So these are the goals of physical therapy for stroke: optimizing sensory motor function and brain health, optimizing cardiovascular fitness and preventing the stroke risk factors of hypertension, diabetes, dyslipidemia, etc. Improving your body composition and musculoskeletal integrity so that you don't develop sarcopenia. And these are some of the ways that we are able to assess their stage in recovery from post-stroke spasticity. This is the Brunstrom staging system. This is used by rehab specialists to see how well a patient is responding to treatment. So for the last part, I'll be talking about post-stroke pain. And while all of the previous factors that I've talked about may involve pain in some way or another, we have to recognize that pain is a very important component that is often not addressed well enough in our patients who are post-stroke. And of course, there are patient-related factors here, such as the kind of stroke that the patient has. Patient demographics also play a part. For example, it has been shown that certain populations have poor thresholds for pain. Others have very high threshold pain. And typically, if you're obese, your threshold for pain is lower. If you have diabetes, your threshold for pain is also much lower. If you're taking any medications, if you have certain comorbidities, and your lifestyle factors and social support. So these patient-specific factors will lead to where on the post-stroke pain continuum you would be. So you can develop conditions like headache. So typically you see this acutely in patients with intracerebral hemorrhage, but headache may persist long after the stroke has improved. Then you can have central post-stroke pain syndromes. So this occurs because of effects of the stroke on the brain's capacity on processing and modulating pain. So our body does not feel pain technically. Our body relays signals that may cause pain to the brain, and the brain is the one that feels that pain. Right? So the way that pain is processed is very important to determining how severe the pain can be. You can also have spasticity-related pain and complex regional pain syndrome. So these are all a spectrum of conditions that can occur after a stroke has occurred. And the most common one, as you can see, the one with the largest continuation is the hemiplegic shoulder pain. It's actually a very severe and very common pain syndrome. And oftentimes, these patients can't very well express how severe their pain is from this condition. So Sir Mac already talked about how we can evaluate pain in patients with language barriers, whether they're intubated or aphasic or have a different language altogether. And we use the CCPOT, or the Critical Care Pain Observation tool, to aid us in determining if our patient is in pain or not. So as you can see here, majority of the pain that occurs in post-stroke patients is musculoskeletal, shoulder pain, spasticity, or headache, and only a very small portion of them have central post-stroke pain syndrome. Okay, and for the diagnosis of central post-stroke pain syndrome, it needs to have a confirmation of a lesion in a brain that can correspond to the area that you're currently feeling pain in. So it's a very specific diagnosis, and it's very, very difficult to treat. So before we end this talk, it would be very good for all of us to have checklists like this. So this is the Canadian Stroke Best Practice Post-Stroke Care Checklist. Thinking of all of these post-stroke complications at the top of your head can be very difficult if you don't do this on a daily basis. So it's very important for us to develop systems like this checklist here in order for us to make sure that we're not missing out on any post-stroke complication. So the components of this checklist include secondary stroke prevention, the capability of the patient to do their activities of daily living, their mobility, the presence of spasticity and pain, incontinence of the bowel or bowels, any problems with communication, mood, cognition, then their quality of life after their stroke, their personal relationships after stroke, the presence of fatigue or any other challenges that they may be facing. So having a checklist like this can really help you in making a systematic evaluation, so that you're sure that you're not missing out on what the patient might be feeling or might be developing. So to summarize this very long talk, hemorrhagic stroke occurs due to the rupture of a cerebral blood vessel, causing focal or global neurological deficits. Hemorrhagic stroke is typically more deadly or causes more morbidity than ischemic stroke, and it can cause immediate, early, and late complications, with the immediate complications including vasogenic edema, intraventricular hemorrhage, and hydrocephalus, and increased intracranial pressure. Your early complications include hyperglycemia, fever, hypertension, and neuroprotection is our primary way of addressing these complications. For the late complications, such as infection, cardiac problems, seizure, bowel and bladder dysfunction, DVT, mental health problems, fatigue, and post-stroke spasticity and pain, all of these things we have to address. And now that we all recognize these problems, that they are possible, what they look like, and what we can do about them, hopefully we'll be able to more effectively manage this. So early recognition and management of post-stroke complications improve long-term outcomes, and especially mortality, morbidity, and functional independence, and of course, quality of life. And of course, this entire process is a concerted effort of every member of the stroke team. And we all need to support one another and the patient so that we can assure good stroke care. So with that, thank you very much.
Thank you. Thank you, Dr. Medrano, for that very detailed and informative presentation, and for sharing multiple guidelines that we can look into in managing complications of post-operative stroke patients. So for those who have questions or clarifications, kindly send your questions through the Q&A box. So while waiting,
Yeah, it was actually really challenging to summarize the talk the way I did, because each of the parang post-stroke complications, you can spend maybe 20
Mm.
to 50 minutes on each of those topics alone.
Yeah, Doc, I've noticed nga rin eh.
Mm.
Talagang sinamarize yung lahat. Thank you and thank you for that. Doc, I just have a few clarifications, actually one clarification to be exact,
Mhm.
about delivery of mannitol. You've mentioned that it should be given via bolus.
Yes.
But in my experience, and I think some of the nurses here with us do also experience that this drug is commonly given via fast drip using gravity
Mhm.
set, or when using an infusion pump, the pump is set at the maximum rate. Can you share your thoughts about that?
Yeah, so the only reason why we want to give it fast, actually there are two reasons. The first is really to prevent any crystals from forming within the tube. So as long as you have a good yung high gauge na IV access, using the gravity set or an infusion pump would actually be more or less equivalent to giving it via bolus. This only becomes problematic if your IV access is very small and it hindi siya nagiging very effective na, because with a smaller na IV, if it moves slowly, pwedeng within the vessel, within the lumen of the catheter itself, pwede siya magkaroon ng crystals, and it can lead to thrombophlebitis. And oftentimes medyo pwede pa nga mag-rupture yung vein na yun eh, with very rapid administration of mannitol. That's why we have to be very careful in using that. The second thing is we want it to be fast, because we want a very sudden shift in the osmolality. So consider parang giving it in 5 minutes versus giving it in, let's say, 30 minutes. In 5 minutes, from, let's say, a serum osmolality of 300, tumaas ka to 325 for in that short period of time. Ang laki ng difference ng gradient na yun. So parang 25, malakas yung osmotic pressure mo for drawing water out of the brain. Whereas if you give it over 30 minutes, for the first 30 minutes, parang mabagal siya. It'll reach 310, 315, 320. It might not even reach 325, unlike the bolus set. And because the gradient is much less, the parang osmotic pressure is also much less then. So those are the two major reasons why we want to give it in bolus, or in short, as fast as you can. Okay,
So
so
give
yeah.
give mannitol as fast as you can, and of course
Mm.
observe for crystallization. Question lang
Yeah.
din po, is it safe to say ba na, or do we need to warm the drug before giving it? Kasi meron akong ibang parang naririnig na mina-microwave muna for a few seconds.
Mm. Yeah, so actually in the Philippines, that's usually not a major problem, because it's actually quite warm in our environment. So in the Philippine General Hospital, for example, it's mannitol is stored in room temperature, which can be at like 30, 32
Yes.
degrees. So it's not problematic. When I was abroad, however, I did notice that they place a heater with the mannitol. It's because sometimes it can be very cold. So like in the ICU in Chicago, the temperature was sometimes mga 16 degrees, 14 degrees. And the nurses there also use infusion pumps or gravity sets. Um, so hindi siya it doesn't flow as fast as usual. So they have a greater rate of crystallization there than we have here. So it's
Yes,
purely by the virtue
usually.
of our environment.
Yeah, I've noticed then
Mhm.
when giving this drug via infusion pump, the whole chamber of the pump
Mm-mm.
nagki-crystallize. So in the end, we need to
Yeah.
change it. So in terms baka mas mapagastos pa.
Yeah.
We have a question here. Any thoughts on using hypertonic lactate solution instead of mannitol to reduce ICP?
Okay, so hypertonic lactate or Totilac is actually a very good alternative for a lot of these hypersmolar agents. And the way that Totilac is supposed to be useful is that it provides the brain with like an energy substrate along with the hyperosmolar treatment. So there are several studies, although most of them are very limited descriptive studies and very small RCTs, that have shown that they are effective. But to my knowledge, I'm just not aware of any very high level RCTs comparing head to head hypertonic saline, mannitol, or sodium lactate. All of these studies that compared these agents um, would be very small, or would have intrinsic limitations to their methodology that you can't make a very strong recommendation. So again, the question therefore, if their efficacies are somewhat similar, your question is cost. Mannitol is so much cheaper than hypertonic saline. It can be, I think it's like 35 pesos for a 500 ml mannitol. Tapos to compound hypertonic saline, there's a pharmacy charge. They have to prepare the materials for that. And so it can cost mga 200 to 300. Then Totilac can cost mga, well, we can ask Delex how much it costs, but it can be quite expensive, especially since their bags are quite small, like 250 ml. So if your patient is in a critical state and money is not a problem, or if you know that you need a very rapid acting agent na 3% yung sodium content, and the patient has very severe traumatic brain injury, you can consider giving Totilac for those patients.
Thank you, Doc, for clarifying that. We have a question here from Gretch. Medyo hindi lang siguro buo yung questions, pero for a patient in acute stroke unit with GCS 15, how long should the patient be in complete bed rest?
So I think it's a no. Complete bed rest is no longer a blanket recommendation for all stroke patients. Okay, so for as long as they are stable, as long as they are not at high risk for falls, they can and they don't have any major physiological problems. Patients with very mild or minor strokes, they may not need any parang restriction like that. Okay, so you just have to ensure safety. So if you in your institution, if this patient was admitted GCS 15, tapos parang wala naman masyadong severe na weakness, they can use a bedside commode immediately. They can walk with assistance. If they have some weakness pa din, they can start using a wheelchair muna, and then you do the rehabilitative process. So it's still recommended that if they do have even mild deficits, that they should undergo rehab evaluation. So I'm spoiled that in St. Luke's is that it's very easy to call for rehab, but in other places it might be a bit more difficult. So in places with limited rehabilitative services, it would really be the nurses who would be doing this early mobilization things. And you don't have to wait 24 hours to do early mobilization in patients with very minor deficits. So the studies that showed that early mobilization within the first 24 hours can be problematic, or in patients with more moderate to severe strokes and with hemodynamic instability, meaning sobrang taas ng blood pressures. So those are the things that you watch out for. Safety, whether it's medical safety or physical and environmental safety. And second is yung trying to mobilize the patients as soon as you can within a safe parameter.
Okay. So mobilization as soon as possible, and of course, maintaining safety. I'm glad that you've mentioned, Doctor, the rehab, no, of a stroke patient, especially na mention na in other institutions wala. So the responsibility will be up to us nurses. So question here is, what do you expect, or how can we help in this in the process of rehabilitation during this stage? Ano yung mga dapat naming gawin?
Okay, so everything that Sir Mac mentioned earlier, and most of the stuff that I discussed, are part of rehabilitative care. So dysphagia screening, which is mostly under the purview of nurses, like the Gogging swallowing score was actually developed by nurses, and most of the dysphagia screening tests and protocols are nurse developed or nurse led. So that is one of the most important things that nurses do in in improving stroke outcomes. So including their VAP bundles of care, instituting good oral hygiene. Then what Sir Mac discussed earlier, patient positioning and posture, and their bed turning. So all of these things are also essential jobs that nurses do almost automatically, but have actually a very large effect on patient outcomes. So with regards to physical therapy, um, what nurses can do is really just assess for or at least keep an eye out for the development of spasticity, assess for any areas that look like they're developing contractures or if they have subluxation, and to address or prevent them from occurring. And one of the easiest ways is really to do passive range of motion exercises. And these passive range of motion exercises include like they start from the upper extremity. So you start with the shoulder, you just move the shoulder around. And you have to support the arm well, especially if this is the weak arm. You just move the shoulder around a few times an hour, and then extend and flex the arm, open and close the hand, move the wrist up and down. So parang just do these movements slowly over time, parang, and then instruct the family. Kasi I'm sure nurses overwhelmed na in general. So if you instruct the family to do this or the caregivers to do this, and you talagang binabantay niyo while you're teaching them, that can be a major help. The same thing for lower extremities. You just move the hip, you move the knee, and then you flex and extend the foot. All of these things are very helpful, especially doing ankle pumps that can really help improve yung parang the speed of regaining ambulation or gait after it.
Okay, thank you, Doc. So, assessment and health education to the patient and the family.
Yes.
Thank you. So, I feel that no other questions will be raised since you've discussed your topic extensively. With that being said, let me award our certificate to our speaker. Okay, so let me read the certificate. The Critical Care Nurses Association of the Philippines Incorporated and the Philippine Neurocritical Care Society award the Certificate of Appreciation to Dr. Jose Miguel Madrano for being our speaker on the topic Managing Post-Stroke Complications during the webinar on World Stroke Day, a closer look in post-op care of hemorrhagic stroke, conducted October 28, 2022, signed by the President of PNCS, Dr. Geraldine Mariano, and the President of CCNAPI, Maria Isabelita C. Rogado. So again, Dr. Medrano, thank you.
Thank you very much for everyone's kind attention, and I hope everyone learned a lot.
Thank you, Doc. Okay, so again, let me remind everyone that this program is applied for 4 credit units. And as you can see in your screen, nakapending status pa po ang accreditation number as well as the credit units. So while waiting, once the PRC gave us the exact accreditation number and the credit units, we will email them to you. So once we've emailed the accreditation number and the credit units, you will receive the certificate. Okay, you can print this out and then write the accreditation number and the exact CPD credit units. Don't take a picture of this. Sample lang po to. Ito po yung marireceive nyo. Blanco po yung accreditation number and CPD credit units. Pag nagpadala na po ang PRC sa amin ng confirmation ng accreditation number and CPD units, ibibigay po namin sa inyo and then pwede nyo pong isulat dyan sa blankong spasyo. Like this. Right? The accreditation number and the credit units. But before you receive your certificate, of course, you must comply with the requirements. You need to take the post test, which will be available at the end of the program, and evaluate the course. Next slide. But before we show the QR code for your evaluation and post test, I would like to inform everyone of our future activities or announcements. Please be advised that we will be we'd like to inform everyone that we have now changed our membership card to electronic. So if you're not yet a member or due for renewal, kindly visit our website under the membership tab to know more about our membership process. On November 8 to November 15, the Critical Care Nurses Association of the Philippines will be conducting a 22-hour course entitled Essentials of Critical Care Nursing. This activity intends to provide the nurses with an overview of critical care nursing practice. The course will present the physiological concepts that will be the basis of understanding the most common illnesses that is related to cardiac, respiratory, and neurologic system in an adult population and the common reasons for pediatric hospitalization. This course will offer an opportunity for nurses to develop critical thinking by integrating knowledge about the disease, assessment, nursing intervention, and collaborative management. Okay, so on December 5 to December 8, this is a 28 and a half hour program that will mainly reflect the essentials and critical aspect of nursing care in a client who is suffering from cerebrovascular accident. This 4-day program will tackle the management from pre-hospital setting up to rehabilitation. In addition, this activity will help the nurse attendees to develop critical assessment skills and a deeper understanding of the disease management and nursing care needed during the acute phase of CVA. Moreover, this training will provide the critical care nurses up-to-date guidelines that are based on American Stroke Association, Stroke Society of the Philippines, and the American Neurovascular Care curriculum. Again, the title of this program is Acute Stroke Nursing Course. Next slide. Kindly save the date of our annual invention. It will be on February 23 and 24, 2023 at Makati Diamond Residences, and it will still be a hybrid event. So kindly save the date, February 23 and 24. With that, you may now scan the QR code in your screen to be directed at your post-test and evaluation, or you may also access it through the link provided in the chat box. Okay, so before we end our program, again, I would like to acknowledge our invited speakers for their time and efforts. Of course, thank you, Delex Pharma, for your continued support to us as our Zoom provider. And to our participants, I hope you will be able to apply the knowledge you've gained in your area and in future endeavors. So for other information and concerns, please feel free to email us at cicinapicpd@gmail.com, or you may text us at 0918-944-6897, or you can reach us at our Facebook page, Sisinapi Nurses. So again, in behalf of the Critical Care Nurses Association of the Philippines and the Philippine Neurocritical Care Society, thank you everyone and have a safe day ahead.
ICU Forum with the aim to bring affordable and quality medicines in the ICU setting. Your prescription doesn't just save lives, but they transform lives to our CSR program.
Sepsis, a life-threatening organ dysfunction caused by a dysregulated host response to infection. Sepsis and septic shock are major healthcare problems, impacting millions of people around the world each year and killing between 1 in 3 and 1 in 6 of those it affects. Shock is common in critically ill patients with COVID-19, developing in up to 67% of patients in intensive care, and is associated with high mortality. In the recent guidelines issued on care of critically ill adult patients with COVID-19, norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. But sepsis and COVID-19 do not only affect the health of the patient. Sepsis and COVID-19 can cause financial burden and has an impact in the environment as well. Although there are positive effects brought about by the lockdown, there is a growing concern in the increasing medical waste generated from hospitals and public's use of disposable safety equipment. Brought about by sepsis and COVID-19, there is a need for an ideal norepinephrine solution to manage hypotension due to shock to achieve mean arterial pressure greater than 65 mm per mercury. A cost-effective norepinephrine to help alleviate financial burden, a norepinephrine that cares for the environment. Norepin is an ideal norepinephrine solution based on clinical studies and guidelines. Norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. Norepin passed the Institute of Pharmaceutical Sciences National Institute of Health in UP Manila with an assay test result of 106.7%. Norepin is cost-effective compared to the Innovator brand and can provide a savings of up to 23,000 pesos. Norepin 10 ml preparation can cut the number of ampules to be opened by 40% compared to the Innovator brand. Thus, it helps lessen the medical wastes. Moreover, Norepin 10 ml preparation has the following advantages. Be a part of our CSR advocacy and World Vision. Your prescription doesn't just save lives, but transform the lives of these children in World Vision. Every time you request Norepin at the pharmacy means sending a child to school and help fulfill their dreams.
How the powerful antioxidant selenium works with vitamins A, C, and E. Vitamins A, C, E, and glutathione are major antioxidants that stop the formation and buildup of free radicals that can cause chronic diseases. For the vitamins A, C, E, and glutathione to exert their full antioxidant activities, selenium is needed. Selenium enhances the absorption of vitamins E, A, and glutathione. In addition, it regenerates and strengthens the effect of vitamin C in the body. Studies show that the combination of vitamins A, C, E, and selenium enhances the immune response of the body against infections and viruses. The activities of selenium, vitamin C, and E in the body are interconnected, and the deficiency of one of these nutrients will have an influence to the others. For instance, selenium and vitamin E may mutually compensate deficiency of each other and act synergistically to slow down formation of cancer cells.